Our achievements: Best Pathology Laboratory of the Year from Six Sigma Excellence Awards 2022. Our achievements: Best Pathology Laboratory of the Year from Six Sigma Excellence Awards 2022. Best Diagnostic Service Provider of the Year. Dynamic Entrepreneur of the Year. Award of Excellence from Diagnostics Leadership Awards 2021. Our footprints: Siripuram, Jilla Parishad and Endada. Dedicated call center support: 1800-3099-199. Our team: Quantum. Quantum Speciality Diagnostics, your right to quality. Vizag's leading and fastest growing NABL accredited Speciality Diagnostics Center. Quantum Speciality Diagnostics, your right to quality. Run by one and only South India's qualified super speciality pathologist, Dr. Upendra Srinivas Mogalu. No outsourcing required to metro cities like Mumbai, Delhi, Bangalore, Hyderabad.
Hello. Good morning, one and all. A warm welcome to the respected dignitaries, faculty members, APMC observer, and our delegates. Thank you for your support and participation in our program, CME and hands-on workshop on flow cytometry and its applications in hemato-oncology and primary immunodeficiencies conducted by Quantum Specialty Diagnostics in association with IMA Visakhapatnam. This is a two-day program with a half day of CME today here, followed by a half day of the workshop at Quantum Specialty Diagnostics, and tomorrow we have the workshop continuation at Quantum Specialty Diagnostics. The program will now begin with invoking the blessings of Lord Ganesha.
महागणपतिं मनसा स्मरामि, महागणपतिं मनसा स्मरामि, वसिष्ठवामदेवादिवन्दितमहागणपतिम् महादेवसुतं महादेवसुतं गुरुगुहनुतं महादेवसुतं गुरुगुहनुतं प्राणकोटि समस्तं देवं महाकार्यनाटकादिप्रियं महाकाव्यनाटकादिप्रियं मूषिकवाहनमोदकप्रियं महाकाव्यनाटकादिप्रियं मूषिकवाहनमोदकप्रियं महागणपतिं मनसा स्मरामि वसिष्ठवामदेवादिवन्दितमहागणपतिं मनसा स्मरामि. Thank you so much.
We would now like We would now like to invite the dignitaries onto the dais for the lamping and inauguration ceremony. I would request Dr. Professor N. Subramaniam Garu, immediate past President IMA AP chapter, to please take the dais. Welcome, sir. Professor Dr. Ramalakshmi Garu, ex-HOD Pathology, AMC Visakhapatnam. Please walk to the dais, ma'am. Professor Dr. Raghunatha Rao Garu, Medical Oncologist, KIMS Icon Hospital, Visakhapatnam. Please welcome, sir. Dr. Shilpa Madam, Assistant Professor, Department Oncology, AMC Vizag, our APMC observer for today. Welcome, ma'am. Dr. Faninder Garu, IMA Secretary, Vizag. Please welcome, sir. Dr. V. Murli Krishna Garu, Surgical Oncologist and Managing Director, Mahatma Gandhi Hospital, Visakhapatnam. Please welcome, sir. Dr. B. Ravishankar Garu, Chief Oncologist, Omega Hospitals. Please welcome, sir. Dr. Bapa Rao Garu, please welcome, sir. I welcome Dr. Rupendra Srinivas, sir, to continue with the program. Please welcome Dr. Kalyan Prasad Garu. Sir, please come onto the dais, sir. I request our dignitaries to please proceed for the lamping ceremony. I now request Dr. Upendra Srinivas Garu to present a token of appreciation to our dignitaries. To Dr. N. Subramaniam sir, immediate past president and IMA. Thank you, sir. Thank you, sir. Dr. Ramalakshmi Garu, ex-HOD RMC. Thank you, madam. Dr. Raghunath Rao Garu, medical oncologist, KIMS Icon. Thank you, sir. Dr. Shilpa Garu. Thank you, madam. Dr. Faninder Garu. Thank you, sir. Dr. V. Murli Krishna Garu. Thank you, sir. I welcome Dr. Professor G. Sambasivara Garu, Principal AMC Vizag, to please take on the dais, sir. Welcome, sir.
Please come, sir. Now we'll continue with mementos.
We now continue with the mementos. Dr. Ravi Shankar Garu. Thank you, sir. Dr. Bapa Rao Garu. Thank you, sir. Dr. Kalyan Ram Garu. Kalyan Prasad. Sorry, sir. Kalyan Prasad Garu. Thank you, sir.
Principal, sir.
Sir, me sir. Ravi Shankar Garu. Dr. Ravi Shankar Garu. Hi, Principal, sir. Professor Dr. G. Sambasivarao Garu. Thank you very much, sir. Thank you for your gracious presence. Thank you, dignitaries. We now begin our scientific sessions. We would like to, sir, please, sir.
Would like to felicitate Dr. Samsara Garu, Principal.
We would like to felicitate Dr. G. Sambasivarao Garu, Principal APMC Vizag and Additional DME.
Sir.
We now start with our academic session. Before we begin the scientific sessions, I request the faculty members to kindly restrict their talk to 14 minutes. Handing over the scientific proceedings to Dr. M. Upendra Srinivas Garu to introduce the academic session. Please welcome, sir.
Good morning, ladies and gentlemen. I sincerely apologize for the little delay in the program because of unforeseen situations. Let us quickly, without wasting time, let us start the academic session for today. The presentation. Okay. As a pathologist, we are often given a task to identify the nature of the cells, whether it be in hematology or in histopathology. We were most often will be given a challenge to identify what those cells are in the context of oncology, cancers, and phenotypes. And the way we actually do them is by doing immunophenotyping, which essentially means we take the principle of immunology, whereby detection of antigen or antibody on the cell surface or the cytoplasm, by doing different kind of test modalities that we have at our disposal. Usually we do it by morphological examination, and then a little bit in hematology by doing the cytochemical stains based on the granular composition and how they are going to react with the dyes. Based on that, we'll be able to identify the phenotype of certain cells in hematology. And in histopathology, largely we do it by a method called IHC, immunohistochemistry. It again is based on principle of detection of antigen on the surface of the cytoplasm by putting an antibody, whereby once the coloring agent is added to it, if it is positive, it will show up a Bryan reaction. That's how we are trained to identify cells in the type and characterization and the phenotype of the cells in hematology and histopathology diagnosis in our day-to-day practice. So today's topic is about flow cytometry, which actually means we are measuring the metrics of a cell or any type of cell when it is flowing in a single line, and the characteristics of that is caught by a laser which detects it. And usually two principles. Based on the size also we can characterize the cells. I'm talking in the context of hematology. By forward scatter, it measures the size of that cells, and in another parameter called the side scatter, which represents the granularity of the cells and the cytoplasmic constituents. These are the two parameters. Based on that, once these cells pass through the cell flow, the laser is going to detect each particle by particle in an automated fashion, whereby having the advantage of counting millions of cells in a shortest possible time. That is the advantage that you get in flow cytometry, which is very relatively easy to do when you compare it with other technologies like immunohistochemistry. So once you capture the data that is obtained by the cells passing through the laser chamber flow, you get the scatter plots based on their size and the cellular composition and the granularity within the cells. They get scattered, and then the software gives us this kind of representation of different types of population of cells, and we can make an assumption as to what that nature of those cells are in the data that we get out of flow cytometry. In all what I just spoke can be put in this particular slide. What morphology can tell you at some times is that there is something wrong. There is some animal. We don't know whether it has got clear-cut stripes or not. So when you add a little bit of technology like IHCs and cytochemistry, we can still say that there is an animal probably having some stripes. It may be a zebra, it may be a tiger. But what actually flow does, it gives more color, and it will be able to identify those cells more accurately, because the sensitivity and the specificity of this technology is so much that it is capable of detection of all these cellular markers, which can actually suggest a immunophenotype of that particular cells that we are dealing with. With that, this is just a basic introduction of what this technology is going to be all about. And with that, I leave the floor to the speakers. We are very fortunate to have a lot of erudite speakers from the local faculty comprising of the top-notch medical oncologists and hematologists of the city, and the national faculty who are I would call them as flow maniacs because all their life they've been doing excellent flow work in institutes like PGI, BL Kapoor Hospital, where there's a huge burden of transplant work also happening. We have a very erudite speaker list today, and without taking much of your time, I will quickly pass on the mantle to announce the next speaker, and then I promise you that we'll keep on maintaining our times from here on. Thank you so much.
Thank you, sir. Moving on to the first session. Moving on to the session on role of flow cytometry in hematological malignancies by Professor Dr. Raghunatha Rao Garu, I would like to invite Dr. Ramalakshmi Garu to chair the session and kindly introduce Dr. Raghunatha Rao Garu. Welcome, ma'am. Welcome, sir.
మీరు అక్కడ కూర్చొని నేను హ్యాండ్ మైక్ పంపిస్తాను.
పర్వాలేదు సార్. I am very happy to introduce Professor D. Raghunatha Rao Garu. I know him also personally. I am very happy to introduce him today for the audience. So, he has interest in basic translational and clinical research in cancer, pharmacogenetics and pharmacogenomics, cancer education and training, networking and collaborations, screening and vaccination. So he has achieved a lot of great things. So first comprehensive cancer center for Andhra Pradesh, first hospital and population-based cancer registries for Andhra Pradesh, first ACRP certified physician from India, pioneered early phase cancer clinical trials unit, benchmarked by University of Oxford, first DM medical oncology program for Andhra Pradesh, national coordinator for training in cancer screening and prevention, NRHM NCD programs, founded the Twin Cities Cancer Club and the Medical Oncologist Forum, Dr. B. C. Rai Award from MCA for outstanding contribution to the development of oncology, authored 280 peer-reviewed publications, 12 textbook chapters, team leader for peer review under the National Cancer Group. So, I am very happy to be with you. Thank you.
Thank you very much, madam. First, thanks for the opportunity to be here. There are actually stalwarts, if you see the program, who is going to deal on specified topics. My job is just to introduce flow cytometry. When I was still a postgraduate student in PGI, I had a chance to work with Professor Sobha Sehgal. That was the beginning of immunophenotyping of lymphomas and leukemias. So my job there was pretty simple. I was asked to steal a lymph node from the surgical OT, section it into two, send one to the histopathology, and the other half I would actually bring it straight to the lab and then help tease out. Most of you probably know Dr. Tarlochan Singh. So help tease out the lymphocytes, prepare uniform mixtures of them, and then use them to, in those days we just did T and B cell enumeration, nothing more than that. Is it a T cell lymphoma or a B cell lymphoma? My additional job there was to look after two animals. One was a bull, the second was a horse, which we actually used to immunize them. So the bull and the horse, whenever the fellow forgot to feed them, would break out of their enclosure and go all around sector 12. So my job was to see where both of them are. The horse was easy, the bull was a little more daunting to bring back to the enclosure. So that was my brush with immunology or immunophenotyping of lymphomas. Most of you know Dr. Sehgal actually pioneered a lot of work in this country on immunophenotyping of lymphomas. When I moved to the Tata Memorial Hospital from PGI, I always had a yen for laboratory science. In those days, a team from Tata Memorial, headed by Dr. Gopal, R. Gopal, went to Seattle to learn immunophenotyping of leukemias along with immunohistochemistry. So they came back, and we did not have a fancy Beckman-Coulter desktop apparatus to do flow cytometry. So we actually did it in test tubes. So you added the antigen, you added the fluorescent dye in steps after getting a phycal hypex separation, and then read it under a fluorescent microscope and marked them as, graded them as say 0, 1, 2, 3, 4. So that is how we did flow cytometry. Much later in, I think 1994, if I remember right, 93, yeah. I actually attended a workshop in Tata Memorial Hospital on flow cytometry when they acquired their first flow cytometer, which is about the length of this stage. So it used to be that big. Now you have fax scans which are smaller than a laptop, and you can do wonders with it. So of course I learned it hands-on. So most of you now, if you ask a technician to do hemoglobin, he doesn't know how to do a hemoglobin. He will ask for a Beckman-Coulter counter. So likewise, you ask a biochemist to say, can you estimate the urea or creatinine? They don't know what urea and creatinine. You take a blood sample and put the plasma in and get a result. So it is a little more different. With automation, you have a little more sophistication. This is just a, you need to see the slides here, or where will they see the slides? Yes, seeing the slides there. I can only see the slides here. Okay, that's fine. Okay, so this is just a idea to give you an idea how the leukemic, our understanding of leukemia has actually progressed over the years, starting from the 80s all the way to the recent era. So over the past 4 decades, in fact, a lot has happened in leukemia understanding. So why did we want to understand leukemias? What did it matter? So when I was still a student in the Cancer Institute doing my DM, the classification was actually criticized. We call them as acute lymphoblastic leukemias, and then in those days we used to call them acute non-lymphoid leukemias. So the other way around, a fellow argued, why can't we actually do the reverse? The myeloid leukemias seem to be uniform, at least except for M3, and the rest of them are acute non-myeloid leukemias. So the controversy kept on ping-ponging. Finally, we left everything. So from morphology, you reach to cytochemistry, from cytochemistry to cytogenetics, from cytogenetics to flow cytometry, and then of course to go through molecular subtyping of leukemias. So why did we do it? One must actually remember that the basic sciences, including pathology, always are about 2 to 3 decades ahead of the clinician in knowing that this is looking something different. So you first recognize the difference either in the presentation or in the behavior or in the outcome to an existing treatment. So treatments actually don't follow so fast as the classifications which the pathologists will introduce. So every 4 years or 5 years you have a pathologist who will come out, a group of pathologists will come out with a new classification. It makes your life miserable. It is something like the CNS tumor classification or the soft tissue sarcoma classification. It makes your life miserable. Is there any meaning to it clinically? No. There's nothing new in as far as the brain tumor is concerned. You can operate and remove, you can give radiation, you can kill him with some chemotherapy. Only 3 options. So you either choose to kill him fast, or you choose to kill him by himself. Only thing. So, but you have so many subclassifications of tumors using molecular biology. For example, Dr. Pathro is very fond of putting a slide in the morning, slide in the evening of all the molecular subtypes of CNS disease, but it doesn't actually get translated into therapy so fast. So to keep pace with that, you require something to happen in the pharmacology and the biochemistry side as well. So let us actually see what exactly is the use. I have just stated those which are relevant to us clinically. There are many others which are relevant for a person from the laboratory. So you can enumerate a leukemic cell population, assignment of lineage. This is important to understand that a lineage is nothing to do with identifying what the cell is. The lineage is actually trying to tell you, in olden days we used to call a leukemia as a arrest in the differentiation of the leukemic cell. So we looked at a leukemia as a differentiation arrest. Something happened in the way the normal maturation was going to happen, and suddenly something got arrested, and so the numbers of cells at that stage are overflowing into the blood. It is not strictly true, but still that holds good as far as clinical management is concerned. Then of course, the most important part is identification of prognostic subgroups. In fact, if you see cytogenetics, the role cytogenetic plays still today, even in the time of flow cytometry, is of paramount importance. So it will tell you, if you don't have a cytogenetic defect, you have normal cytogenetics, you are unlikely to do well, even if you have all the good parameters of a girl who is about 6 years old, who has got an acute lymphoblastic leukemia with a count less than 50,000, a normal platelet count, and a almost near normal hemoglobin. She has got all the parameters, including that she is Caucasoid. But still, if you have a normal cytogenetics, they are not going to do well. So it is important to use this prognostic grouping to know that your therapy you have needs to be refined. So if the treatment you have is not likely to have an impact on what this patient probably has. And subsequent post-therapeutic monitoring, you have a wonderful lecture on post-therapeutic monitoring, so I will not touch those aspects. I have just listed them here. So this is what I meant by understanding what is the lineage differentiation of early hematopoietic cells. I have chosen the simplest of the graphs. I have drawn this as simple as possible, but not too very complicated. So important to understand that there is a lineage and something happens at a molecular level to drive it. Some switches are switched off, some switches are switched on, so a differentiation occurs. In the past, I used to do in vitro growth of patients from MDS. If you see an MDS growing in the petri dish, you will be astonished. So how to identify whether it's an erythroid colony or a myeloid colony, so or a thrombocyte colony? It's very simple. Wait 2 more days, the whole colony starts turning red. So it is as simple as that. So that means it is producing red blood cell, it is incorporating iron, and it can now grow into something very beautiful. So it is as simple as that. So if you remember that, then it is enough. So this is a simplified flow chart for the diagnosis of acute leukemia. Don't worry about this chart. You are going to be explained in detail of what and how to go about using a protocol for everything. Now, majority of us are very familiar with this cluster differentiation designation. This is only a name. We used to call it by different names in North America, in Europe, in say Far East, in Australia. The same molecule or the same antigen or the same epitope got a name which that researcher wanted to use, but all of them got grouped through a designation, which is the CD. So the CD79 in the older textbooks or older papers would be referred to as something else. So if you are referring to older literature, you will probably need to know what it was called some time back. For example, the Kala antigen. Okay, so you know that if it is expressing Kala, that it is CD10 positive. So something like that. So it used to be called by many other names, but to avoid a controversy and promote communication, you have a cluster of differentiation which helps you group them into, be so-called B lineage, T lineage, or myeloid lineage with high specificity, medium specificity, or low specificity. What you need to understand that they are not watertight compartments. The purpose of my graph here is to tell you that there are some antigens which are expressed early on, there are some antigens which are expressed late, and some antigens are expressed throughout, some are lost midway, some are acquired midway. So it is important to understand that there is a lot of overlap between the groups of, they are not watertight compartments, they don't actually work like that. So when you are in a controversy, you can go back to this to refer and say, yes, of course, I know that even for a thymocyte, which is going to the school in the thymus, you need to acquire many things to know. You have an epithelial tutor there, which tells you this is self and this is non-self, and how to recognize this. So the expressions change, and then you know from the original cell what could be the leukemia which might remember. That means there is a normal counterpart of the phenotype, and from there you get an abnormal expression, so that you correlate between these two. Likewise, the others also, I am also giving you an example of chronic lymphoproliferative disorders. These used to be a rarity. 10 years back, we never had a classification of flow cytometric classification or a cytogenetic classification. Now we know the importance of cytogenetics and flow cytometry even in CLL for prognostication, early treatment, and of course knowing whether your treatment will work or not. So is there a correlation between the FAB classification and the expression of antigens? It is plus minus. Some are non-controversial. Yes, of course, there seems to be a very good correlation. So is there morphologic flow cytometric correlation? Yes and no. It does appear to be positive as well as negative. So you need to know that morphologically many things may be different. So you can subtype what looks morphologically uniform into different subgroups which are prognostically of relevance to you. That is of the importance. So likewise you can do it for ALL, and likewise you can subclassify an ALL into precursor B, common ALL, pre-B ALL, and mature ALL. So this is useful for prognosticating and your treatment choice for that child or for that adult. It is important to understand that this is a method of actually trying to choose the best possible treatment for that person. Likewise for TALL, and so on and so forth. A word about the so-called differences between a biphenotypic leukemia and a bilineage leukemia. Well, of course, there is, some people have a confusion of what is what. So there can be an overlap and there can be an acute bilineal leukemia, two different blast population markers expressing distinct lineages, or a single blast population expressing multiple lineages is a biphenotypic. Well, you can use an biphenotypic leukemia subtyping to do it. Now, many a time what happens is there must be a good laboratory control as well as good sample collection to achieve this. This is what is important in quality control for phenotyping. It is important to understand that most of the equipment and the reagents you use need to be tropicalized. While the flow cytometry and the pathologist are always at 16 degrees centigrade, the lab ward and the patient are not at 16 degrees. They are typically at 40 or 42 degrees centigrade. So it is important to understand that the transport can happen through a lot more temperature variation while you transfer that to the laboratory. So what works there need not work at every place. So is your transportation, collection, sample processing, everything intact? And everything is of course time bound. From there you will know it. So in short, what I tried to tell you is that phenotyping is of great use, not for just recognizing what is the lineage, how to classify the leukemia, how to prognosticate, but also to many of the other applications which will be of great use. As you go along today, I'm sure you will understand from each one of the speakers the importance of this type of lineage classification using immunophenotyping. Thank you for your attention.
Thank you, Raghunandarao garu. It's a very nice lecture. Because I'm a little older woman, I would like to tell what happened when I presented my cases in 1978, a research work, what I have done for my professor, Dr. Shyamala Bhaskaran. I used to do T-cell rosettes. I don't know how many of you remember the most preliminary work, but our professor was very active, and I was the first PG in the medical college. I was made to do all this research work. So I used to do T-cell rosettes by getting the rabbit's blood and all, and I presented this case in our Usmania Medical College national maybe cytology conference. Then Dr. Bhaskar Reddy garu commented, I know only large large lymphocytes, small lymphocytes, madam. I do not know all these things. So probably at my experience, I will tell T lymphocytes, B lymphocytes, CD34, CD3, like that. But now people will talk depending upon the flow cytometry, the advanced techniques depending upon the fluorescent technique, and also by genetics. So, and actually, still I practice online reports I will be giving. So now and then hematology cases, I refer for flow cytometry. Whenever I have a doubt, these acute leukemias, whether this myeloid or lymphoid, and we are very happy that Upendra has got the solution here. So I am really very happy, and we are helping the patients, and I thank the radiotherapists and oncologists for helping the patients and curing the patients very nicely. Thank you so much.
Thank you.
I request Dr. Ramalakshmi garu please to hand over the token of appreciation to Dr. Raghunatha Rao sir. Thank you, sir. I request Raghunatha Rao garu to please hand over a token of appreciation to Ramalakshmi madam. Thank you, sir. Thank you, ma'am. Moving on to the next session, it is role of flow cytometry in acute leukemia by Dr. Bhaskar Bhuvan garu. I would like to invite Dr. Shilpa garu to please come and chair the session and kindly introduce Dr. Bhaskar Bhuvan garu. Welcome, ma'am. Welcome, sir.
మా ఇది ముందే ఇవ్వాలి. Good morning, one and all. At the outset, I thank the organizer, Dr. Upendra Srinivas garu, for giving me this opportunity. Dr. Bhaskar Bhuvan is a medical oncologist and transplant physician at HCG Cancer Center, Vizag. His areas of interest include running cancer awareness programs for the public, focusing on high-risk groups to detect cancer at earliest, clinical and lab research in solid and hemato-oncology, to improve the single institutional clinical, psychological, social quality of care for all stages of cancer patients, academic and teaching activities, and fluent in all the languages. I welcome Dr. Bhaskar Bhuvan to deliver his talk. He'll be speaking on flow cytometry in acute leukemias.
Thank you, Dr. Upendra Srinivas sir, for this wonderful opportunity, and excellent lecture by Raghunath sir. He made my job easy relatively. So today my topic is flow cytometry in acute leukemias. Okay. 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 So let us go back to the history of flow cytometry. See, various scientists around the globe contributed to the today's development of the flow cytometry, like Paul Ehrlich, who described the staining of properties of fluorescein. Moldova in 1934, he described the photo detection of the cells and particles. And Kunz, who detected the Streptococcus pneumonia by using UV light, UV excitable fluorochrome conjugated antibody. And Coulter, he's a biomedical engineer. He described the sizing of the particles, the cells, based on the microscopic properties. And MacJet Fulweiler, who is the person who designed the forerunner of the present flow cytometry. In 1978, the name cytophotometry was officially changed to flow cytometry at the conference of the American Engineering Foundation. What this flow cytometry means, as my previous speakers told, flow means fluid or moving, cyto means cell, and metry means measurement. So what exactly it has? It has a solid chamber with one small pipe where the cells will flow in a single sheath manner, single file manner. At one point, only one cell can pass through this tube. One excitable laser will pass the light where, based on the size and granularity, forward scatter and side scatter will be seen, which are detected by the optical system sensors, and that voltage the voltage signals generated by the optical system is converted in the electronic system to plot a graph. So basically it includes fluid system, optical system, and electronic system. So if you see the plots, usually, as I mentioned previously, forward scatter usually interprets size, and side scatter usually granularity. You can see the sizes of various cells of normal hematopoietic cells like platelets. All this will have lesser size and less granularity. That's why they are plotted earliest in the plot, where the granular sites are bigger in size as well as have a lot of granules. So they are put in the last quadrant. So the next table you can see that how it is quoted as positive or negative based on the y-axis and x-axis. So usually the this chamber usually converts as the positive, whether both the x-axis and y-axis turns out to be positive. So what to see? So we understood how to read the plots. So what to see? So first we have to identify or quantify the cell population within the given sample, whether it's a whatever blood or bone marrow sample. Then we have to differentiate from normal to abnormal. Once it turned out to be abnormal, then you have to find out whether it is a reactive cell or neoplastic cell. Once you find out it's a neoplastic cell, you have to find out the differentiation or maturation stage of that particular cell. And finally, once you find out the exact maturation stage of that cell, then you have to find out the quantification of the particular tumor content. So what samples to be taken? So usually blood and bone marrow aspirate are the best. In fact, bone marrow aspirate is the best because blood has some kind of other cells also will be usually contaminated. So additionally, we can do on CSF, FNA cytology, ascitic fluid, and pleural fluid also we can do. So we all know that the hematopoietic system usually includes, it's very quite simple. So one is lymphoid progenitors or myeloid progenitors. In lymphoid we have T cell, B cell, and NK cell. In myeloid, usually erythrocyte, megakaryocyte, mast cell. Apart from that, myeloblastic picture, we have monocyte, basophil, eosinophil, and neutrophil. So in these 7 classifications, usually the myeloid picture will be seen, and in that lymphoid, around 3 types usually we see. So this is the most difficult part. Okay. So how to diagnose acute leukemia based on the flow cytometry? It is the simple chart where it all summarizing all the kind of markers. So first, before diagnosing for the sample, once you have suspicion of acute leukemia based on the blast population more than 20%, then initially we have to put immature markers like CD34, TDT, HLA-DR, along with one myeloid marker like MPO, B lymphoid marker like CD19 and 17A, and 22, and CD3 T lymphoid marker. These markers initially we will screen. Once if it comes to be any of particular lineage like B lineage, B cell ALL, then you have to do the further classification. You have to do additionally CD10, CD20, mu heavy chain. In case if it turns to be CD3 positive, which is this T cell marker, then you have to do CD1A, 2, 4, 5, 7 like that. If it turns out to be MPO positive with immature markers also consistently positive, then you have to do additionally 13 and 33, 117, CD16. So sometimes myeloid markers can be negative, so you have to do the additionally monocytic markers like CD14, 64, 36, and 4. More specific is the CD300 is one which it is more, very much specific to the monocytic variant. Next, erythroid and megakaryotic are relatively very rare, but the kind of CD markers for erythroid like CD235A, which is also called glycophorin A, is very specific to it. And megakaryocyte also, megakaryocytic leukemia can also have strong expression of CD61, 41, and 42. I know it's very difficult to remember, but by repeatedly using these numbers, only we can identify. So first, we'll see how you diagnose ALL. So usually, majority of the ALLs express TDT and CD34 markers. But to diagnose it's a B cell ALL, usually CD19 should be strong positive. At least CD19 should be strong positive, along with additional one marker from CD20, 79 and 22, one additional marker should be strong positive. So total 2 strong markers are required to diagnose it is B cell ALL. In case CD19 is weak positive, then out of the 3 markers, at least 2 markers should have strong positivity. So historical importance, we previously classified BALL as pro-BALL, common ALL, that is Kala positive antigen ALL, and a late pre-BALL. Usually pro-BALL have CD19, 79, and 22 positivity, but when it achieves CD10 positivity, then it is called Kala positive antigen. And if CD10 is lost and mu chain is attained or CD20 is there, then it is called pre-BALL, which is most commonly seen in children. So this is a plot of one of the patient. So you can see that CD 10 and 20, 19, 79 all are positive in these plots actually. You can, if you see. So usually this picture is CD10 positive is Kala positive ALL. Like you can see that here in this numbering you can see that CD10 is negative, but 2 strong markers, that is CD19 and 20 are positives along with CD79A. So which defines the criteria. So it is a pre-BALL. So this is also an interesting case. Here CD19 is strong positive if you see in the first plot, but CD10 is negative. So we need another marker to diagnose B cell ALL. So here CD79A is dim to moderate positive based on this picture they had given, but proactively just we got the CD22 also done for this patient. So he got CD22 also positive around 30%. So finally he was diagnosed pre-BALL. So we gave the targeted therapy related to the CD22. He had excellent response. So when it comes to the T cell ALL, it's not like B cell where 2 strong markers are required. Here only one single marker is enough. That is CD3 strong positivity is enough. But it can be associated with the CD7 also, but it is not mandatory to be associated. But CD7 alone cannot diagnose T cell ALL. Always CD3 is required. So in this plot you can see that patient has CD3, 7, CD5 all are positive along with CD45 marker. So other T cell types are also present. These are all historical and academic interest only, because for the WHO classification, these variants are not mentioned. For pro-TALL, usually CD3 and CD7 will be positive. Pre-TALL, additionally CD5 and 2 will be positive. For cortical T cell ALL, where it comes in thymus, then CD1A has to be additionally positive. So another variant, recently everyone is starting using this ETPLL, that is early precursor T cell ALL. It is one of the worst prognostic kind of ALL where patient will not cross his induction period in majority of the cases. Okay, in this case, usually CD3 can be positive, but CD1A and 8 will be negative, 5 will be dim. And associated one myeloid or stem cell marker usually has to be positive. In this graph, it is picturized. So when it comes to the AML, it is more complex, heterogeneous. At single time, we can see 2 different maturation forms like M1, M2, like that also. So usually the immaturity markers like CD34, HLA-DR, 117, these are usually positive. And monocytic markers can also be positive. Main important strong marker is myeloperoxidase is usually positive. So in this patient, you can see that patient has positive for MPO 33, 34, and 117 HLA-DR, where monocytic markers are not that much positive. So that's why patient is diagnosed as AML EM1 without maturation. So APML, this is an interesting thing, because usually APML morphologically we can come to a conclusion because of the high granularity, and cup shape morphology of the cells. But additional and flow, the most interesting is the high side scatter because of the high granularity in the APML patients, APML cells. So the side scatter will be very high, which equivalent to the complexity and granularity of the cell. So usually the immature markers like HLA-D are usually negative, but rather CD117, 33, 13, these are positive in APML patient. So when the granules are relatively less, then we call hypogranular variant. So AML M5, monocytic variant, where the usual markers like myeloid are less positive, MPO, all these things, but more commonly monocytic markers like 64, 300E, these will be more positive in monocytic variant. So another interesting diagnosis is the MPAL, mixed phenotypic acute leukemia. So as per the WHO 2000 criteria, so usually for myeloid, either MPO or one monocytic marker should be present. For T cell, CD3 has to be strong positive. B cell, again like the previous explanation, B cell diagnostic criteria, CD19 has to positive with one additional marker, CD22. So you can see in the third graph where you can see that this patient has CD3 and MPO, both are positive in this patient. So another variant which described in the classification of acute leukemias is the blastoid, plasmacytoid, dendritic cell neoplasm. So this variant usually doesn't have the markers like other AMLs. So usually it will have HLA-123 strong positivity, and HLA-DR will also be strong positivity, along with the CD4 strong positive, CD56 strong positive in this variant. So once you do completely, go through these flow cytometry samples repeatedly, then only we can remember all these things. But just this is a pictorial representation of all the markers what I spoke. So what additional information we'll get from flow cytometry? Yes, it is definitely gives diagnosis of the acute leukemias. So additionally, some FCM markers when present in the flow cytometry plots, so you can anticipate this patient can have particular translocations, like in B cell ALL, CD34 negative with CD9 positivity is present along with CD10 and mu chain positivity, then we can anticipate that translocation 119, which is a high risk marker translocation, can usually associated. In early pre-BAL, that is pro-BALL, so usually have HLA-DR positive, TDT positive, CD15 positivity. This kind of variant usually associates with MLL type of translocation, that is translocation 411, which is also a high risk marker. And Kala positive ALL usually have CD10 positivity, but if associated CD66 and CD25 positive there, so chance of getting BCR APL positivity is very high in this group. So like pro-T lymphos ALL also can have such TLX and TAL1 kind of genes associated, which is a relatively favorable risk, even though T cell is a bad risk diagnosis. For AML, if it is with the B cell lineage like CD19 or 79A positive, then chance of getting translocation 821 positive, which is relatively favorable risk. And we know that APML have PML RARA positivity, which is a favorable risk. So what else? Apart from prognosis, diagnosis, we can also predict response to the targeted therapy. Like in AML, gemtuzumab ozagamicin, which is a CD33 antibody, so which is used commonly in the first line therapy of AML. And in ALL, rituximab, CD20 targeted therapy, inotuzumab, as I told for my previous patient, we had excellent response, and blinatumab, all these are target based, that is CD22, 19 based. So all this information can get through FCM. But still, even though FCM gives diagnosis, but still for the proper tailoring of the therapy and complete management, we require additional cytogenetics and FISH and RT-PCR, because WHO classification requires all these additional investigations. So summary, FCM helps in diagnosis of various acute leukemias precisely. Pre-BLL requires strong CD19 positive along with another strong marker from the panel. T cell ALL requires only CD3 strong positivity enough. AML stem cell markers along with MPO usually positive. It will help in prognostication of the acute leukemias and also helps in predicting the response to the targeted therapy. But additional FISH cytogenetics and PCR testings are required to tailor and further management of the therapy. Thank you.
Thank you, Dr. Bhaskar Bhuvan. Now the session is open for discussion. 1 or 2 questions, please, may be accepted from the audience. So if there are no questions, we'll move to the next session. Thank you, Dr. Bhaskar.
Thank you, ma'am.
Thank you, sir. I request Dr. Shilpa Garu to please present a token of appreciation to Dr. Bhaskar Bhuvan Garu. I request Dr. Bhaskar Bhuvan Garu to present a token of appreciation to Dr. Shilpa Garu. Thank you, ma'am. There is a small announcement before we move on to the next session. As we are running a little behind on our schedule, tea and coffee will be served at your respective tables. Thank you. Moving on to the next session, it is on role of flow cytometry in minimal residual disease in acute leukemia by Dr. Rakesh Reddy Garu. I would like to invite Dr. Bhagyalakshmi Garu to chair the session and kindly introduce Dr. Rakesh Reddy Garu. Welcome, ma'am.
So good morning. Dr. Rakesh Reddy, Chief Medical Oncologist, Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam. And he did his MD DM, MD Pediatrics from PGH and Chandigarh, and DM in Medical Oncology from AIMS, New Delhi. And he's a Chief of the Medical Oncology, Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam. So welcome, Dr. Rakesh Reddy.
Thank you, madam. Thank you for this kind words of introduction. At the outset, I take this opportunity to congratulate Dr. Upendra Srinivas Garu for the stupendous success of quantum diagnostics, as well as bringing such unique program on flow cytometry, bringing such experts on flow cytometry so that we can be benefited, the general pathologists in the city can be benefited. Congratulations, sir, and thank you at the same time. So the previous two speakers have spoken about flow cytometry and its application in acute leukemia. I'll be taking it a step forward in a more focused direction, like role of flow cytometry in MRD detection. So what is this MRD? So we know that about 90% of children and about 50% of adults achieve remission with induction chemotherapy. So we have an acute leukemia, we give induction chemotherapy of about 1 month duration in both ALL and AML. And at the end of treatment, we do a bone marrow to assess how much percentage of blasts have decreased. So if you have, like say 70-80% blasts to begin with, and the blasts come down to less than 5%, we call it as a morphologic remission. But do all of these patients get cured? No. A good number of patients, they still do relapse. Why is this happening is that residual leukemic cells that escape detection by conventional techniques like morphologic assessment, even by a good pathologist, a cytogenetic assessment. So the limit of detection is much lower for these technologies. So if you see this particular graph, a 10⁻², that is a 1% reduction, still will have almost 1 billion residual cancer cells in the body. So even if they remain quiescent for some time, it is understood that they will start proliferating again and they will start to manifest relapse. And detection of this particular disease, which is below the threshold of detection of a conventional technique like light microscopy or cytogenetics, is called MRD. It used to be called minimal residual disease. Nowadays the term is measurable residual disease. And this MRD is now documented as an important prognostic factor in management of both ALL and AML. So my talk will be from a clinician's perspective, how I use MRD in my patients, and it is directed towards other clinicians, my co-clinicians and general pathologists. It is not for the experts in flow cytometry who obviously know much better than me. So if I do slip up, please let me know. So what is the need of MRD? Is a light microscopy not enough? So achieving a complete remission is primary goal of induction chemotherapy. Induction is what we give in the first 1 month. So whether we achieve a morphologic remission or whether we achieve a deep remission by detecting something known as MRD is vastly different. So morphologic and cytogenetic methods are prone to less limit of detection, around 5%. They are operator dependent, like one pathologist might see 3% blast and another pathologist might see 6% blast and say that this is not a complete remission. And a patient who is deemed to be a morphologic CR, that is, let's say if the pathologist gives at the end of induction therapy 2% blast, he still can harbor around 10 billion leukemic cells. So this is a huge load that is still there. Only we have cleared the tip of the iceberg, the rest of the iceberg is still underneath. Then there are what are known as hematogons. These are benign lymphoid precursors, and especially when a patient is recovering from chemotherapy or for transplantation, these benign lymphoid precursors, they proliferate in marrow and they appear very close morphologically to blasts. So a pathologist on light microscope may end up giving a higher percentage of blasts, and it is very difficult to differentiate on light microscopy. But flow cytometry can differentiate hematogons and blasts. And then there is a possibility of sampling error because marrow can have heterogeneous response, like one area can be completely cleared and another area can still be so all these techniques, they limit light microscopic morphology as a method to assess complete response. So a complete response for an acute leukemia is better defined by MRD. The techniques of MRD, they should be sensitive, they should be specific, that is, they should be able to differentiate a blast from a non-blast cell. They should be able to pick up a blast from a more tens and thousands of normal cells, and they should be applicable, easily applicable and reproducible across labs. Suppose I send to lab A and gives some value of MRD. If I send the same sample to another lab, they should have any reproducible value within a limit. So for this, the preferred methods are flow cytometry or a polymerase chain reaction or NGS, next generation sequencing. PCR can detect MRD by immunoglobulin and T cell gene rearrangements in either BALL or TALL, or sometimes we have these chromosomal rearrangements like Philadelphia chromosome T922, where we can detect the BCR-ABL transcript. T1517 PML-RARA, we can detect that transcript in PCR. So it makes our job easier. NGS is a more advanced molecular technology and it's much more sensitive, and its role is coming up in flow cytometry, in MRD detection. So these are the sensitivity. So if you have about a standard microscopy can detect 5,000 blasts per 10,000 nucleated cells. So if there are 10,000 nucleated cells, 1 lakh nucleated cells, a standard microscopy, morphologic microscopy can detect about 5,000 blasts. That is about 5% sensitivity. Compared to a flow cytometry, it can detect about 1 in 10,000 normal cells, 1 blast in 10,000 normal cells. PCR can detect maybe 0.1 to 1%, 0.1 to 1 in 10,000 normal cells, and NGS can detect almost 1 in 10 lakh cells. So it is much more sensitive. So my specific topic is flow cytometry for MRD, and the limit of detection is 1 blast in about 10,000 cells, and it is applicable method of to detect measurable residual disease in almost more than 85% of BALL and vast majority of TALL. So in TALL especially, the leukemic blast, they always express TDT, terminal deoxin transferase, CDT, cytoplasmic CD3, CD5 and CD7 in addition to other T cell antigen. So this kind of pattern is not seen in a normal T cell in the marrow or peripheral blood. So it makes flow cytometry very easy to differentiate. So to extrapolate in a clinical sense, in a clinical scenario, Suppose if you have a TALL in on diagnosis from one lab, you can use that report to detect, to send for MRD at the end of induction to another lab, because that report itself is enough. But conversely, for a BALL or for an AML, you need to have the MRD assessments done at both the same labs. Like a leukemia associated aberrant immunophenotype needs to be defined for a BALL and AML upfront in the same lab, and the MRD assessment also has to be repeated in the same lab. So there is also something known as sequential MRD monitoring by multiparametric flow cytometer, that it is the end of induction, at the end of consolidation. So this is a well documented prognostic marker. So the advantages of flow cytometry vis-a-vis PCR or vis-a-vis NGS is, it is widely applicable, it is easier to establish for a lab, the speed of which you get a report in one day, it is quantitative. So you get a report of 0.01% or 0.1%. So even for a lay physician like me, it is easy to understand. So I will keep in mind, okay, less than 0.01% or more than 0.0%. It is as easy for me to interpret. So you get additional information sometimes for targeted therapy, as Bhaskar was mentioning, and you can do it in a marrow or a peripheral blood sample. So the disadvantages are false negativity. So even if the MRD mentions it to be negative, especially in the later months of treatment, like for example, if 6 months have passed or 1 year have passed, there is something known as lineage shift. So initially the blasts are expressing certain CD cell surface markers, and later on the cell surface markers have changed because of the evolution of the blast. Sometimes you have low cellularity sample, if you drag on more than 5 to 10 ml, so it gets diluted by peripheral blood. So the low cellularity sample, you might not pick up enough number of cellular events. And as I was telling, baseline sample is needed for certain situations. So coming to ALL and AML, so how is MRD applicable? For ALL, there is absolutely no doubt from a clinician's perspective that MRD is an important prognostic factor. It is performed at various term points, and it also determines whether you can escalate therapy or de-escalate therapy. And the common technologies are used as, mostly we use flow cytometry. For certain situations, we use PCR also. Like for example, Philadelphia chromosome positive ALL. It is very easy to use PCR. But you have to understand, for a PCR to be used, there has to be specific constructs of primer that needs to be there prepared. So the lab has to be standardized for that. And NGS is evolving. Bone marrow sample is considered the standard, and only for NGS MRD you can interchange both bone marrow and peripheral blood. Otherwise, for flow cytometry, bone marrow sample is considered standard. So I was saying that we have no doubt in mind of using MRD in prognostication. So this is the largest data set, a meta-analysis of almost 13,637 patients across 39 studies. 60% of them are pediatric patients and 40% of them are adult patients. And the hazard ratio of overall survival, this is the gold standard marker, overall survival, who have MRD negativity compared to who had MRD positivity, the hazard ratio is 0.28 for overall survival. So if a patient has MRD negativity compared to the patient who had MRD positivity, the reduction of death chance is almost more than 70% if there is a MRD negativity that is achieved. So very clear that it is a very good prognostic marker. So it is consistent across therapies, across the methods and times of assessment, whether you do by flow cytometry or whether you do by PCR or whether you do by NGS, the threshold levels and the subsets of ALL, whether for BALL or TALL. Specifically in pediatric ALL, we use either flow cytometry or PCR, and for pediatric ALL, the data is highest as for the impact of this measurable residual disease as prognostic factor. The first time point we do is at the end of induction, that is at the day 29 marrow, and we take a threshold for positivity as 0.01%. Okay, so if the threshold comes as more than 0.01%, you consider it as MRD positive, and if it comes as less than 0.1%, it is considered as MRD negative. And it is a predictor for higher chance of relapse if MRD is positive at the end of transplant also. Like for example, this patient of mine, a young boy who has a high risk ALL, less than 1 year old. So if you do a flow cytometry at the end of induction, you can clearly see in this report that it is mentioned there is no immunophenotypic evidence of residual disease. So the MRD value has come as less than 0.1%. So even in the report, there is the number of events that are acquired is mentioned, the total number of viable events were mentioned, total CD19 positive events, and it is clearly mentioned that these are hematogons, that there is a progressive maturation of CD10, 19, 20, 38, 34 and 45. So this kind of progressive maturation of CD markers is not seen in a atypical cell like blast. It is seen in only a benign lymphoid precursor like hematogon. So that is how flow cytometry will help to determine the extent of response that the patient has got, as well as whether the abnormal looking cell that we are seeing is a hematogon or a blast. And I said that it is used to alter therapy. In ALL there is data, like if there is a positive MRD in this prospective trial of 200 odd patients of intermediate risk ALL, patients who had MRD positivity were either consolidated with transplant or just continued with the conventional therapy. And those who had consolidated with transplant, the overall survival is 64%, and those who were continued continued receiving conventional chemotherapy, it was only 24%. So it is a marker to intensify therapy. It is a marker to de-escalate therapy also. Like for example, if there is a good risk ALL and if MRD is negative, we can decrease the number of cycles of intensification that we give. So that is pediatric ALL. In adult ALL also, we use the adult ALL, more number of patients are pH positive, so we can use RT-PCR in them. And if they are pH negative, we use flow cytometry. It is prognostic, there is data to that also. If there is a patient who had an end of induction marrow negativity, they are low risk, and the 3-year disease-free survival is 100%. And if MRD is positive at end of 1 month and at end of consolidation, the 3-year DFS is only 6%. So 100% to 6%, so a lot of difference. And there is data existent to escalate therapy also. So what I do is, if the patient has MRD positivity at end of induction and at end of consolidation, I routinely take them up for allogenic transplantation, especially in adult ALL. Coming to acute myeloid leukemia, so MRD, minimal residual disease, is evolving and awaiting standardization. So PCR, FCM are being used, but there is uncertainty here. If the association of MRD positivity and relapse are well correlated, like for in ALL. Like in ALL, I have shown you multiple studies which are showing a good correlation. Here the correlation is not as good. And the therapeutic consequence is also not well established. Suppose if there is MRD positivity, do I intensify therapy? Is a question mark. If PCR can be used if there is a fusion gene transcript like T821 or T1517, or there is gene mutations like NP1, NPM1 or RUNX1, or an aberrantly expressed gene like WT1. So if these are well established in your baseline sample, you can use the same to construct a PCR primer and follow an MRD. If they are not there, then probably flow cytometry scores better, and a baseline LAIP, that is leukemia associated immunophenotype, needs to be defined and used as technique. But it requires an extensive panel to establish an LAIP, and some leukemic cells may not express LAIP, and they may change, the LAIP also may change with time. So these are limitations. So this was one prospective study of 240 patients. The MRD cutoff here is 0.1%. It is different from ALL, where it is 0.01%. Here it is 0.1%. And about 23% of patients had MRD positivity after 2 cycles of induction. And those who had MRD positivity, so there is a higher cumulative incidence of relapse at 4 years, that is 72%, versus those who had MRD negativity. So there is some data to suggest that it is a prognostic marker. What is the therapeutic consequence is something we are still learning. So what I do is I do a serial measurement assessment. Like if the patient is MRD positive at the end of induction, I do it at the end of consolidation again, after 3 cycles of consolidation that we give for AML. And suppose if the patient is still MRD positive, like let's say this particular child, he had MRD positivity at the end of induction, the value is 0.3%. I continued 3 more cycles of consolidation. This is apparently a T821 good risk ALL, but with lot of extramedullary disease, even CNS disease was there. So at the end of consolidation, the MRD has risen to 9.9%. So I did a transplant for this patient, and now he is MRD free. So this is how I would use FCM for MRD in AML. So to conclude, it is an important prognostic feature in ALL. It is well established. It guides treatment decision. The impact is more well established in pediatric ALL. It is in flow cytometry. MRD is a very easy, well reproducible, has well defined cut points and time points in ALL. But in AML, it is still a process in evaluation. It has some limitations, as I mentioned, to preclude widespread use, but serial monitoring might help in specific situation. With this, I end my talk. I bring warm regards from my hospital as well as from my transplant unit that is in Health City, Arlova. We have done 70 plus transplants, and thanks to Dr. Upendra Srinivas, we were able to do much more advanced work. Thank you.
So, Dr. Rakesh Reddy, it is an excellent and lucid presentation. And what is the importance of hemoglobins and the differentiation with the flow cytometry in the minimal disease MDS? It's very excellent. And we congratulate you and your team for your excellent work in the bone marrow transplantation from Mahatma Gandhi Hospital. Thank you.
Yes.
Madam. Okay, yes.
Samples, is it only the blood or any other tissue can be subjected to this?
So for ALL specifically, madam, the question that you asked, you have flow cytometry as the initial diagnosis. So once the diagnosis is established, we do induction chemotherapy, and we do a marrow assessment at the end of induction chemotherapy to assess the baby or the patient has achieved a remission or not. So you have a morphologic report suggesting that there is no increased blast. Then you send the same sample for MRD assessment by flow cytometry. And if the flow cytometry report comes as less than 0.01%, then we, of blasts are present, then we say that this is MRD negative. If there is more than 0.01%, like 0.3% or something, we call it as MRD positive on flow cytometry. So even if the patient has achieved a morphologic remission, he can still be MRD positive by employing more sensitive techniques like flow cytometry.
Only blood or any other, sometimes we ask, where do you look for the recurrence, in what tissues it's more common? Like
right, madam. So we can use peripheral blood, we can use bone marrow, you can use CSF. Sometimes you have leukemic involvement in CSF, that you can use. And sometimes cell suspensions can be created from lymph nodes also, and these can be run for flow cytometry also. So tissue can also be used specifically, but not for MRD assessment. For initial diagnosis, we can still use.
Oh, thank you.
Thank you, madam. Thank you.
Thank you, sir. I would request Dr. Bhagyalakshmi Garu to please hand over a token of appreciation to Dr. Rakesh Garu. I request Dr. Rakesh Garu to please hand over token of appreciation to Dr. Bhagyalakshmi Garu. Thank you, ma'am. Moving on to our next talk, role of flow cytometry of chronic lymphoproliferative disorders by Dr. U. Ramesh Garu. I would like to invite Dr. Praveena Moona Garu to chair the session and kindly introduce Dr. Ramesh Garu.
First of all, I would like to thank Dr. Upendra Srinivas for giving me this opportunity. Now, I would like to invite Dr. Ramesh Uppada Garu, who is a clinical hematologist and hemato-oncologist and bone marrow transplant physician at HCC Cancer Hospital. Sir, you can start your. His educational qualification is He is senior medical hematologist in Department of Hematology. His areas of interest are benign and malignant hematology and stem cell transplants. His special areas of interest are acute leukemia, CMPN, aplastic anemia, and bone marrow transplantation. Sir, you can start your session.
Thank you, madam, for your kind introduction. Thank you, Dr. Upendra Srinivas, sir, for giving me this opportunity to stand in front of you. Thank you all. Good morning and good morning to all my teachers, colleagues, and my friends here. So I'm proceeding with my topic of flow cytometry in chronic lymphoproliferative disorders. I think this is a vast topic. I just want to cover only a few important things and briefly run through the things. So we just want to know the clonal proliferation of lymphocytes by using the flow cytometric technique in CLPDs. So this is all the WHO classification of B cell, T cell, NK cell lymphoproliferative disorders. And for diagnosing chronic lymphoproliferative disorders, directly going to flow cytometry is absurd. So we should see the morphology first, then his architecture of the lymph node, morphology, and then only we should proceed for what panels we have to use in the flow cytometry. For all learning physicians or pathologists, so they should know that before proceeding to flow cytometry of any disease, they should see the peripheral smear first. So you can see the reactive follicles and the effacement of the nodal architecture. Then morphology, usually in CLPDs, the morphology, small cells with scant cytoplasm, they will be categorized into CLL, mantle cell lymphomas, marginal zone, and low-grade follicular lymphomas. Small cells with moderate cytoplasm, hairy cell leukemia and marginal zone lymphomas, and small cells with eccentric nucleus and lymphoplasmatic cells, lymphoplasmacytic lymphoma and marginal zone lymphoma. And mixed small cells, cleaved and large blastic cells, they will be like follicular lymphoma, sometimes CLL, prolymphocytic leukemia, and mantle cell lymphoma. And large cells with or without vacuoles, so high-grade lymphomas like follicular, DLBCL, Burkitt's lymphoma, and blastoid variant of mantle cell lymphomas. So this flow cytometric technique, we want to get our cells of interest. And this use of flow cytometry in CLPD is to know whether they are reactive cells or neoplastic cells, and separate the lymphoid population from non-lymphoid populations. So role of flow cytometry to assess the clonality and to diagnose or subtype any disease using the aberrant antigen expression or identifying the surface antigen expression, then evaluation of prognostic markers, detection of target molecules for therapies where CD20 expression will use rituximab and CD30 will use brentuximab. And as Dr. Rakesh Reddy already spoke, it is important to detect the minimal residual disease. So briefly going through this, this is a conventional B cell CLPD classification where CD19 is a pan B cell marker. So all B cells express this CD19, and to subtype we'll get these CD19 cells and we'll see for expression of CD5 or CD5 expression is not there. If there is CD5 expression, and we'll see further markers if there is CD23 with a dim CD20 and either kappa or lambda light chain restriction with a dim, and this will categorize into CLL. And if it is CD5 positive with CD23 negative, bright CD20 and bright surface immunoglobulin, and with cyclin D1 positivity, will categorize into mantle cell lymphoma. So, and coming to other side where the CD5 expression is not there, so CD5 negative cells will look for CD10 positivity or negativity. So CD10 positivity identifies its origin from germinal center B cell, and the neoplasms will categorize as follicular lymphoma, DLBCL, and Burkitt's lymphoma. And see now the tumor cells with CD5 negative and CD10 negative will assess with further markers using like CD123, 103, CD25, and 11C. So to subtype like hairy cell leukemia variant, splenic marginal zone lymphoma, lymphoplasmacytic lymphoma. So this is a brief image showing how we will get. So CD19 B cells, there is no light chain restriction. So when there is no light chain restriction, so it is malignant cells show either kappa or lambda. There will be light chain restriction. This is important feature of malignant cells. When there is no light chain restriction, it is categorized as reactive nodes. Excuse me. But if these gated CD19 cells show light chain restriction, now as I already discussed, if with CD5, so this CD5 positive cells with CD23 positivity will go ahead with CD200 and confirm it as CLL. And if there is CD5 positive with CD23 negativity, then we can think of mantle cell lymphoma. We will confirm by CD11-14 translocation, sorry, T. And when with the light chain restriction, there are CD10 positive cells, germinal center derived lymphomas like follicular lymphoma, DLBCL, and Burkitt's we will think of. And now coming to CD5 negative and CD10 negative CLPDs with CD11C positivity and but not showing CD103, but CD103 negative, it goes as splenic marginal zone lymphoma. And when CD510 negative, CD11C positive with CD103 positive and CD25 positive is hairy cell leukemia, and CD25 negative is hairy cell leukemia variant. And okay. And CD10-5 negative with CD11C negative. When 11C marker is negative, and again going by morphology, large cells DLBCL and small cells lymphoplasmacytic or marginal zone lymphomas. So these are all the things which I have discussed. Now coming to T cell CLPDs. So this is vast topic again. I will just briefly show. Usually CD3, CD2, CD7, CD5, and we will use these markers, antigens for diagnosing T cell neoplasm. But see, along with CD4 and CD8. So when there is CD4 and CD8 negativity, say this one, CD4 and CD8 positive, double positive cells, they will come under T cell pro-lymphocytic leukemia and T cell lymphoblastic lymphomas or leukemias. Then CD4 positive but CD8 negative, they will be categorized as T cell PLL and mostly cutaneous T cell lymphomas, anaplastic large cell lymphoma and adult T cell lymphoma or leukemia. And CD4 negative and CD8 positive in cytotoxic T lymphocytes, they will be like natural killer or natural T cell, NK T cell neoplasms and T cell lymphoblastic leukemia lymphoma. So this one, double negative. And when coming to CD8 positive, there will be T cell large granular cell lymphocytic leukemias and hepatosplenic T cell lymphoma, which is gamma delta variant. So just running through this, see, there is positivity of CD3 to CD4 markers in T cell lymphomas with CD7 positivity and CD25 variable expression is T cell pro-lymphocyte leukemia. And in adult T cell lymphoma leukemia, leaving aside the morphological thing, which is there will be some flower shaped cells, CD7 will be negative and CD25 there will be positivity. And cutaneous T cell lymphomas, Sézary syndrome, along with these T cell markers, there will be loss of CD7 and variable expression of CD25. So I am not, see, coming to this anaplastic large cell lymphoma, along with these markers, there will be loss of CD5 and CD7 is important in anaplastic large cell lymphoma and adult T cell leukemia lymphoma. Along with in adult T cell lymphoma leukemia, there will be CD25 positivity, which is characteristic. And plasma cell neoplasms, so CD38 and CD138 markers we use to separate lymphoid from plasma cell, to separate plasma cells from other lymphoid cells. I'm sorry. So you can see there will, normal plasma cells show positivity of CD19, and CD20 is not expressed. But in abnormal cells, there will be CD19 is lost with expression of CD20, and there will be abnormal expression of CD28, CD56, CD117 in malignant plasma cells. This is important thing. And in contrast, this CD19 is positive in Waldenström's macroglobulinemia. Usually CD19 will be expressed in, will not be expressed in malignant cells. See, just though this looks awkward, I picked up some time to write this. See, this is a quick summary. CD2, 3 positive, so we'll go ahead with T cell lineage markers. And if there is CD4 positivity, along with CD25 positivity, it is adult T cell leukemia, oblique lymphoma, and CD25 negative will go with T cell lymphomas and PLL. And T cell lineage with CD8 positivity, it is T cell large granulocyte lymphoma. Then CD19 positive, it is B cell lineage. Now CD5 positive with 23 positive, and CD20 dim surface immunoglobulin dim with CD200 positive is BCL, and CD23 negative with expression of surface immunoglobulin FMC7 along with CD200 negativity with cyclin D1 positive is mantle cell lymphoma. Coming to CD5 negative with CD10 positive follicular Burkitt's and DLBCL, and CD5 negative, 10 negative with CD11C positive with CD25 and 103 expression in hairy cell leukemia, and 25 negative is hairy cell leukemia variant. So to summarize, flow cytometry in CLPD, we want to see the limitations of flow cytometry here are when there are large number of reactive lymphocytes with only few malignant or atypical cells, there will be confusion how to proceed with this cases. And for any flow cytometry, the sample should be fresh and unfixed. So we cannot use samples of long duration. Okay, thank you.
It's a nice presentation, sir. Any questions to our speaker? Okay, thank you.
Thank you, sir. I request Dr. Praveena Garu to present a token of appreciation to Dr. Ramesh Garu. I request Dr. Ramesh Garu to present a token of appreciation to Dr. Praveena Garu. Thank you, sir. Thank you, ma'am. Moving on. Our next session is on role of flow cytometry in myelodysplastic syndromes, paroxysmal nocturnal hemoglobinuria, and hereditary spherocytosis, which was supposed to be taken by Dr. B. Chandrasekhar Garu, but he could not attend due to some personal reasons, so the talk will be taken over by Dr. Upendra Srinivas Garu. Welcome, sir. I request Dr. Rakesh Garu to please come onto the dais and chair the session and introduce Upendra, sir.
So I got the best job for today to introduce the such a fantastic personality. He is my predecessor at both PGI and Chandigarh and AIMS New Delhi. So Dr. Upendra Srinivas Garu, even though he doesn't need any introduction, I still have a very honorable job. So he is MBBS from AMC Vizag, MD Pathology from PGI Chandigarh, DM Hematopathology from AIMS New Delhi. Thank you, sir, for sharing the same alumni as me. So He worked in leadership roles and laboratory directorship in several national and international tertiary care hospitals and oversees all the laboratory specialties. He is a regular faculty in various conferences. He is on executive committee of several pathology associations and multiple national and international publications. He is currently senior consultant pathologist and hematopathologist and managing director at Quantum Speciality Diagnostics. And if I may add to that, he is a very good dancer. He has excellent dancing skills and very good cricketer as well. So with this brief introduction.
Thank you, Dr. Rakesh, for that extension in my introduction. Good afternoon, ladies and gentlemen. As a organizer, I can be both rewarded as well as punished, but this time I would want to be punished because of the delay in the program slightly a bit in the beginning. I would restrict my talk as a very, very simple basic level. Knowing the audience matrix is at a postgraduate physicians and pathologists and general physicians who are practicing a little bit of hematology. So I promise that this is going to be a very at a most basic level. And the topic that I'm going to do on behalf of Dr. Chandrasekhar, who was supposed to do it, but he could not do in the last minute, is a slightly, uncommon indications or uncommon usage of this particular technology, these hematological conditions. Let me start with myelodysplastic syndromes for that topic. And usually for the undergraduates and physicians and pathologists, myelodysplastic syndrome, the name itself speaks. Myelodysplasia is something dysplastic changes happening in the bone marrow. That is what it actually says. Clinically, when you encounter a patient who has got an organomegaly and a pancytopenia or a bicytopenia or some sort of a cytopenia, which is essential for any myelodysplastic syndrome, we may sometimes see cytopenias very commonly in our day-to-day practice, but not all of them don't qualify for being called as a myelodysplastic syndrome. The symptomatology is any drop in the lineages, like if it is an erythroid lineage problem, you may have anemia. If it is a leukocyte related problem, it will have a leukopenia and thereby neutropenia, which will predispose the patient to the neutropenic sepsis. And if it is a platelet problem, you have a bleeding diathesis, bleeding manifestations, mucosal bleedings, on all that may be part and part of the clinical presentation criteria. And the starting point for any hematologist to actually move towards making a direction of, diagnosis of MDS is to have a good look at the peripheral blood smear, where you can sometimes, apart from cytopenias, you can have a subtle morphological changes which may not really give away a lot of information as to what is happening in the bone marrow. These subtle changes can be in the form of a Pelger hue anomaly in the neutrophilic series, which are only hypolobated forms and hypogranular forms. All that may slightly morphologically, as a soft point, as you can take them, that something must be happening wrong in the marrow in terms of dysplasia happening there. So that is the morphology part, and you then would like to, and there is any transfusion-dependent anemia, if an elderly patient who has got persistent cytopenias, then we would recommend a bone marrow examination. In that, what we actually look for in a bone marrow morphology is the dysplastic changes in all the three lineages. The dysplastic changes that you have are in the erythroids, multinuclearity, in the increase in the size, in the bizarreness of the cells, and irregularity of the nuclear margins. You have atypical mitosis happening, anything which is not happening in a normal way in terms of proliferation that should happen at a normal pace. If it is not happening, that actually amounts to ineffective erythropoiesis or inactive hematopoiesis if it involves all the three cell lineages. So across all the lineages, we have dysplastic changes morphologically. The moment you see if these dysplastic changes are amounting to quantitatively more than 10% of the counterpart cellular constituents, then you can as well maybe considering a possibility of a myelodysplastic syndrome in that. This is another neutrophilic ring in neutrophils, what you call, if you make a complete circle of the lobation of neutrophils, you can call them as a dysplastic neutrophils. These are certain of the morphologically soft pointers that you can suggest a possibility of a myelodysplastic syndrome. Bone marrow biopsy also, there is something called ALIPS. ALIPS is abnormal localization of immature precursors. The tendency of the blasts that come, actually they come very close to the trabecular bone mass, and then gradually they will infiltrate the entire bone marrow space. That's what happens initially in a myelodysplastic syndrome. There are few IHC markers which we can run and then probably point out a more confirmatory diagnosis in myelodysplastic syndrome as far as the morphology is concerned, but that is not sufficient to make a clear-cut diagnosis of myelodysplasia. Then the other investigation that we usually do is doing a fish cytogenetics by looking at different cytogenetic abnormalities, because essentially what happens in the biology of myelodysplastic syndrome, you have genetic damage at the core that happens to the hematopoietic stem cells, thereby that leads to dysplasia and all the lineages. So FISH is a technology in which you can do that. There are a whole lot of 5-6 cytogenetic abnormalities. Based on that, the risk stratification also of myelodysplastic syndrome is used to be, is still done. And the markers, because certain set of cytogenetic markers will point towards a particular kind of a risk stratification in cases of myelodysplastic syndrome. So cytogenetics, but the trick of the thing here is that in cytogenetics, our FISH panel for myelodysplastic syndrome, hardly 50% of the cases you have any genetic damage, that is visible genetic damage that can be picked up by FISH. So what happens to the other 50% which we don't have any cytogenetic abnormalities? So there comes this is a classification which is there out there in the literature. Any new entrant and new student and postgraduates, they can always have access to this classification. It keeps changing. Now more and more the myelodysplastic syndrome is moving towards a molecular diagnosis, and probably very shortly there may be a classification just based on NGS, which is nothing but next-gen sequencing, is going to come very shortly. And no, myelodysplastic syndrome is a pre-leukemic condition. Anytime it can transform into a leukemia. But exactly what is the genetic changes, what is the morphological, what is the molecular level changes that happens based on that, the risk stratification as well as the diagnosis also will come into work very shortly once this new technologies also come into practice. The special word about flow cytometry in MDS, you sort of tend to see the maturation patterns that actually the experts will demonstrate the cases that they have in the workshops for the students who have who are participating in the workshop. And I'm not going to spend much time on this. So there are different patterns where you can actually suggest. The most important differentiator that one has to keep in mind is to say that the cytopenias that we are seeing is clonal or not. And the other cytopenia that we can have is, as I was telling earlier, is a reactive cytopenias. How do we distinguish? What are the few multi-parametric parameters that we can actually look for in flow cytometry to make at least a indication towards myelodysplastic syndrome? So the other entity would like to touch upon is paroxysmal nocturnal hemoglobinuria. Is a old terminology where the hemolysis of red blood cells usually happens at the night time because of the drop in the oxygen. There is a buildup of carbon dioxide in the bloodstream, and then that acidifies the serum. That activates the complement. It will destroy the erythroid series of cells, which essentially have a basic underlying genetic defect, which is a glycosylated phosphatidyl inositol anchor protein. It's just called as a GPA anchor proteins, and there are two proteins especially which play a role in pathophysiology of PNH, which is CD55 and 59, whose essential role is to prevent complement-mediated lysis of the erythroid cells. That is what essentially happens in paroxysmal nocturnal hemoglobinuria. It again is a self-explanatory. A lot of hemolysis happens intravascularly. All the hemoglobin gets pent up and it will pass through the renal system. Thereby in urine you can sometimes can detect hemocytin. That is one of the investigations that earlier we used to do in paroxysmal nocturnal hemoglobinuria. The basic criteria for a PNH is that it arises in a setting of a bone marrow failure syndrome. So what happens is, if the entire cellularity of the bone marrow is wiped off, the cells, especially of the erythroid lineage cells, they try to get a survival advantage because of what is happening in the immunological destruction part of the bone marrow failure. They attain this survival advantage. Because of that, those clonal populations will stop exhibiting on the surface the proteins which are responsible for preventing them from attack by the complement-mediated lysis. I know it's a little bit too much of pathophysiology packed into a small paraphrase, but that is essentially what happens. So in PNH, you will have intravascular hemolysis, and the other characteristic feature that happens in PNH is unusual site thrombosis. If you have a Budd-Chiari kind of a presentation which we don't know what is the etiology for, and you have a cerebral cortical venous thrombosis or if you have a testicular and a scrotal kind of thrombosis, unusual site thrombosis or a bilateral kind of a thrombosis, this is something that we need to suspect in a background of a pancytopenic peripheral picture. So these are clinical presentations. As I said, it is all intravascular hemolysis and then thrombosis that can happen, cytopenia related problems. Earlier, the way we used to diagnose PNH is by doing a ham sucrose lysis test. In essentially, what it does is that it exposes the RBCs to the sucrose, which is supposed to activate the complement and see whether this lysis is happening in them or not. If lysis happens, that means they are deficient in the proteins that are responsible for preventing them from complement-mediated lysis. The other refinement that happened subsequently is based on the gel card method, in which you are essentially looking at CD55 and CD59 expression on the erythroid cells in a gel card method, which is very commonly used in all the blood banks. But the disadvantage of this is it's not a very highly sensitive. It's a small clone. It may miss that, and if it is a transfused blood also, sometimes you will not be able to accurately diagnose on this methodology. And it is not a quantitative data. So that has given rise to the requirement of a additional technology, which is a very sensitive and specific for detecting a PNH clones. There comes the role of FCM. So in this, essentially what it is even in transfused patients, you can detect the deficiency of those proteins which are GPI anchored, not only in erythroid series, but you can detect them even on monocytes and neutrophils. That clearly gives us an advantage that flow cytometry based testing can be done in patients who are transfused. You don't have to necessarily test them on erythroid cells. You can test them on neutrophils and monocytes by gating them and picking them up into 157 and 24 positive and 14 positive monocytes and 24 positive neutrophils. All those cells can be gated and see the expression of some protein called FLAIR. FLAIR is a protein which is supposed to attach to the GPA anchor protein on the surface of the cells. So this protein, if it is bound, it will be tagged with a fluorescent dye. Once the cell passes through the flow cytometry laser chamber, it gets detected. So in this, what we can actually, there is something called mosaicism. The cellular mosaicism is 3 different types of cells with the 3 different types of intensity of expression of GPA anchored proteins can be seen. They are like mild to moderate to severe deficient population of these cells, which have that much limited expression of FLAIR on them. So based on that, we can see if the type 3, which is a severe deficient one, is more, then the hemolytic part will be more. So you can see the spread out of this mosaic population of cells on the histograms of the flow cytometry that we look at. The last indication in this special session is that hereditary spherocytosis, which is a very common hereditary hemolytic anemia that we may come across in our day-to-day practice. And any elderly, young patient with a hepatosplenomegaly, with gallstones, hemolytic anemia features, and on the peripheral smear, if you are seeing spherocytes, dark, small cells, then what is the actual test that can give a confirmation or near confirmation of hereditary spherocytosis? Very minimal and very subjective tests are available. Now, we know what is the basic defect in hereditary spherocytosis, because it is a problem in on the RBC wall. We have some structural proteins. If you have a problem in that structural proteins, all these vertical proteins usually lead to hereditary spherocytosis, and the horizontal proteins that form the cytoskeleton of an RBC, they lead to a condition called elliptocytosis. That needs to be distinguished between the two entities. Now, what we are actually used to do in hereditary spherocytosis for diagnosis is the osmotic fragility test, which suffers from a very, very severe subjectivity. Sometimes it may not be accurate. So that has given rise to the role of FCM. FCM basically uses one particular dye called 5-eosin melamide, and this dye has a strong affinity to go and bind to the cytoskeletal membrane proteins. Obviously, if the membrane proteins are deficient, the binding capacity also will come down, and the binding capacity is actually measured when these cells are processed and submitted to the laser chamber in the flow cytometry. Because of the deficiency of the protein, their uptake of the binding dye is also less. So that shows that they are deficient cells. This is what you are seeing in this picture. Whereas on the control, you see a good expression of binding of the dye to those cells. So that means they are all having a normal cytoskeletal binding proteins for the dye. Whereas in hereditary spherocytosis, you clearly see there is a deficiency in the mean fluorescent channel intensity. That's the parameter that you check. If it is less, then you are pointing towards a diagnosis of a hereditary spherocytosis. With that, I stop my session, and then if there are any quick questions, otherwise we'll move to the next session. Thank you, sir.
Wonderful talk, sir. As usual, nothing short is expected from you. Any questions for our eminent speaker? If there are none, can I see his? If there are none, can we go ahead with the next?
Yeah, please.
I request Dr. Upendra sir to kindly issue token of appreciation to Dr. Rakesh sir. Thank you, sir. Moving on to the next session, role of flow cytometry in multiple myeloma by Dr. A. Praveen. I invite Dr. Ramesh Uppada Garu to kindly chair the session and introduce Dr. Praveen Garu.
Good morning, everyone. Thanks for giving opportunity to introduce Dr. Praveen, A. Praveen. He has done his DM Medical Oncology from Nizam's Institute of Medical Sciences, and he is working as consultant medical oncologist in Apollo Institute, Arilova. So he has so many presentations at various conferences, national, and he is a member of American Society of Clinical Oncology and European Society of Medical Oncology. So with this, I hand over mic to Dr. A. Praveen. You can proceed.
Very good morning to all of you. Thank you, Dr. Ramesh, for your quiet introduction. I congratulate Dr. Upendra Srinivas Garu for his excellent organization and the first time in Andhra Pradesh, one of its kind workshop plus molecular pathology CME after so long. We have been waiting for this for so long time. Hearty congratulations, sir. Yeah, my topic is multiple myeloma and role of flow cytometry. Yeah. Now, we will be going through the talk in these subheadings. First, we'll be looking at the disease biology, later diagnostic criteria, response criteria, and role of flow cytometry and FISH. This is the basic picture depicting the myeloma disease progression. Just remember that plasma cell dyscrasias is not a single disease entity. It is a battery of disorders. And to diagnose them, we should do a compulsorily battery of tests to diagnose them or at least to rule out them. So initially, the initial disease biology gets originated from the post-germinal center B cell with the various inherited events such as primary genetic events, whether IGH translocation or hyperdiploidy. Later, the disease progresses to MGUS or smoldering myeloma, or later it progresses to myeloma and plasma cell leukemia because of various secondary genetic events. This picture clearly depicts the disease biology. Initially, normal plasma cells from the post-germinal center B cells. Then they will get exposed to the primary cytogenetic abnormalities, either most of the translocations involving the chromosome 14 with other chromosomes, or trisomies, or both. Later, they will get exposed to secondary cytogenetic events, and they progress from MGUS or smoldering myeloma to dangerous myeloma. And with further acquiring of secondary cytogenetic abnormalities, the patient may develop or have either a relapse or a refractory myeloma and extramedullary disease or plasma cell leukemia. So these are the various advances in the technology that has helped in understanding the disease biology of the myeloma. Initially, way back in 1995, the G-band technique and translocations are known. Later in 2000, we came gene expression arrays. Later in 2005, we got a classification of, that is the molecular classification. And recently, based on next generation sequencing, we can know that because of the various NFKB pathways, this is the main reason for multiple myeloma. This is the same picture that we saw previously. This is the disease biology of the plasma cell dyscrasias progressing from to MGUS, smoldering myeloma, high-risk smoldering myeloma, and multiple myeloma, and finally plasma cell leukemia. So generally, these patients, myeloma patients, they generally don't come directly to the hematologist or oncologist. They present to either orthopedicians or general physicians with complaints of bone pains or low backache or paresthesias of the both lower limbs because of the cord compression, or they generally present to the nephrologist because of the decreased urine output and renal failure. So during that evaluation, they come up with some findings such as lytic bone lesions or other, some of the simple findings that help us in suspecting myeloma are raised DSR, Rowlea formation in the peripheral smear, and altered AG ratio. Whenever we see them or we see some lytic lesions in X-ray or radiographs, and then we suspect the myeloma, then we do further workup. Just remember, to rule out myeloma or confirm myeloma, we definitely should do a battery of tests. Single 1 or 2 tests is not sufficient. The most important of all are is serum protein electrophoresis, immunofixation, free light chain assay, and bone marrow aspiration and biopsy. The role of flow cytometry in the diagnosis of myeloma is evolving, but is not established per se, but it is there in response criteria evaluation. So these are the diagnostic criteria of International Myeloma Working Group. You can see at the bottom, that is the diagnostic criteria for monoclonal gammopathy of undetermined significance. It should meet all the three. Serum monoclonal protein less than 3 gram per deciliter or 30 gram per liter. Bone marrow should contain clonal plasma cells less than 10%, and absence of the myeloma defining events that all of us know, the famous CRAB criteria, hypercalcemia, creatinine, anemia, and bone lesions. So less than 3, less than 10%, and absence of CRAB criteria or myeloma defining events will diagnose the MGUS or monoclonal gammopathy of undetermined significance. If at all the patient is having SP of greater than 3 and the clonal bone marrow plasma cells vary from 10 to 60% and absence of myeloma events, then he comes under smoldering multiple myeloma. So coming to the myeloma, if the patient has greater than 10% plasma cells along with or extramedullary plasmacytoma with one of the CRAB criteria, that is serum calcium greater than the 1 milligram per liter, the upper limit of the normal, or creatinine clearance less than 40, or serum creatinine greater than 2 milligram per deciliter, along with anemia that is less than 10, and bone lesions, 1 or more lytic lesions on the X-ray. So clonal plasma cells less than 10%, less than 3, with absence of CRAB criteria, it is MGUS. It is greater than 3, 10 to 60% plasma cells with the absence of CRAB criteria, it is smoldering myeloma. And it is greater than 10% with end organ damage, it is myeloma. And recently also they have proposed new criteria, that is way back 4 to 5 years back, that even though above the all findings are not there, if the clonal bone marrow plasma cells percentage is greater than 60%, that single criteria is sufficient enough to diagnose the patient as a multiple myeloma, or involved by uninvolved serum free light chain SO greater than 100. Even though this single finding is also there, we can diagnose the patient as multiple myeloma, or greater than 1 focal lesion on MRI. So these are the specific criteria based on which we can diagnose multiple myeloma. This is the molecular classification of the myeloma. As we said previously regarding the primary cytogenetic abnormalities and secondary cytogenetic abnormalities, above the translocations regarding chromosome 14, 4, 14, 11, 14, 6, 14, 14, 16, 16, 20, and below are the hyperdiploides. This is the normal, this is the karyogram depicting the various hyperdiploid chromosomes. Gain of chromosome 15, 9, and 19 are the most frequent. This is the same prognostic translocations regarding 14. And this is the NGS picture depicting that main NFKB pathway, histone modifying enzymes, and RNA processing, that is the main disease pathology involving the myeloma. This is the same predictive prognostic panel. So now we know the diagnostic criteria of the myeloma and disease biology of the myeloma. And while going for diagnosis, it is essential to send the bone marrow aspiration specimen only for a prognostic panel. It can't be done on a blood sample. So we should ensure that while doing bone marrow aspiration procedure, we should collect some amount of bone marrow aspiration blood separately for prognostic panel if we are suspecting myeloma. And once we diagnose the myeloma and we prognosticate him, this is the initial single chart depicting the initial management of the myeloma. First, we should understand whether the patient is transplant eligible or ineligible, whether the patient is transplant candidate or not candidate, because autologous stem cell transplant is the only thing that can prolong disease-free survival significantly, and we can save these patients for many years with autologous stem cell transplant only. So our flowchart starts there. If at all the patient is a transplant candidate, we treat him various regimens depending upon the risk. If it is a standard or intermediate risk, we can treat him with VRE. Some people are treating high risk with KRD regimen. Those are the various drugs that are used in myeloma. And after 3 to 4 cycles, we do a response evaluation and consolidate with autologous stem cell transplant and give maintenance with either lenalidomide or bortezomib. If at all patient is transplant ineligible, then we try to treat them with VRD regimens. If it is so frail and he is having severe neuropathy and other comorbidities, then we can treat with other various regimens like MPT regimen also. So one thing to remember is we should categorize the patient into transplant eligibility or ineligibility and treat him according to the risk based on the prognostic panel. Why do we need to prognosticate these patients? Why do we need to do FISH and look for the other molecular translocation and everything? Because the survival varies based on these prognostic markers. Because if at all that 13q deletion is there, it is a good prognostic marker and they do comparatively well. And if at all deletion 17p is there, it is a poor prognostic or high risk feature and they doesn't do well. You can see here in this picture, on the top, this is a Kaplan-Meier curve. You can see that if at all that deletion 17p is there, the survival is almost 22.2 months. If at all it is not there, it is 45 months. So the survival is almost double. So it is for the understanding of the clinician and to explain to the patient also, we should definitely do this prognostic panel so that for the prognostication and better understanding of the disease biology. So now coming to the response criteria. In response criteria, we have the role of this flow cytometry. Flow MRD negative, that is absence of phenotypically aberrant clonal plasma cells by next generation flow on bone marrow aspirate. So previously we are talking about we are hearing the talks of Dr. Rakesh and all. Ma'am has asked a question on which sample we got to send it for doing flow cytometry. In myeloma, you should definitely send the bone marrow sample only. So in myeloma, you should definitely send for bone marrow sample. So absence of the aberrant clonal plasma cells by NGF on bone marrow aspirate will give us whether the flow is negative or positive and everything. And people also do MRD on next generation sequencing also. This is the response criteria. There is complete response and there is stringent complete response. Complete response means negative immunofixation on serum and urine and less than 5% plasma cells in the marrow post-treatment. Less than 5% plasma cells and negative immunofixation on serum, it is complete. 0% plasma cells, that is stringent CR. Less than 5% CR, 0% plasma cells is stringent CR. In the similar way, partial response and very good partial response. PR is greater than 50% reduction in the serum M protein. Whether next very good partial response is greater than 90% response. So just remember that way. Partial response is greater than 50%, very good partial response is greater than 90%. Progressive disease, any increase in the serum protein or immunofixation, urine M protein or bone marrow clonal plasma cells, it comes directly under progressive disease. Relapse from MRD is also the same thing. Loss of MRD negativity on flow cytometry, the patient comes under relapse from MRD status. So this is the follow-up criteria. So we have looked at the disease biology. Just remember the diagnostic criteria and prognostic panel. We have looked at how do we treat these patients, and we have looked at the response criteria also. The role of flow cytometry is definitely there in response criteria. It is becoming evolved in the diagnostic later in the near future. This is the sample report of the prognostic panel. This is the FISH, which Dr. Upendra sir must be getting in the near future in our quantum also. So these are the various prognostic markers based on which we prognosticate the patients of myeloma. This is the sample MRD report, where you can see that myeloma MRD 0.02% of the all nucleated cells. Previously, Dr. Ramesh also said about the plasma cell markers, CD38, 138 and 56. So they will get the atypical population in almost 10 power 5% of the cells. So, and they will identify that any clonal plasma cells are there based on this expression of the CD38 and 138, and it will give the MRD report. Because of the various developments in the last decade and availability of the bone marrow transplant, autologous transplant in various health schemes also, myeloma is in the verge of developing into a chronic disease where we can save these patients with, for many years also and treat them comfortably with oral medications and subcutaneous injections too. Thank you.
That's a great talk by Praveen. He has briefed up myeloma in such a short time. And with this topic is open for discussion. If there are any questions from audience, we can take. Okay, so we'll move on to next topic. Thank you, Doctor.
I request Dr. Ramesh Garu to present a token of appreciation to Dr. Praveen Garu. Thank you, sir. I request Dr. Praveen Garu to present a token of appreciation to Dr. Ramesh Garu. Thank you, sir. Moving on to our next session, role of flow cytometry in bone marrow transplantation by Dr. Ramavat Devendra Naik Garu. I would like to invite Dr. Anil Handu Garu to kindly chair the session and introduce Dr. Ramavat Dev Garu. Welcome, sir.
So thank you very much, and it is indeed my proud privilege to be introducing Dr. Ramavat Devendra Naik. He is a medical oncologist, has done his DM Medical Oncology from All India Institute of Medical Sciences, New Delhi, and currently he is at he's a Chief Medical and Hemato-Oncologist at Omega Hospital, Visakhapatnam. Over to you, sir.
Thank you, sir, for that sweet introduction. And I would like to thank Dr. Upendra Srinivas also for giving me such a good opportunity and making me on board. So my previous speakers have done a wonderful job in enumerating various benefits or various roles of flow cytometry in different clinical disorders. Now I would be talking about role of flow cytometry in bone marrow transplant. Hope I will do justice to this topic. Let's moving on. So these are the few possible applications of flow cytometry in BMT. Quantification of hematopoietic stem cell transplants in the graft and quantification of CD34 positive hematopoietic stem cells in the peripheral blood. These are the two most important indications of flow cytometry which we use in a day-to-day clinical practice or bone marrow transplant setting. And apart from that, we do have a minimal residual disease which is gaining an importance nowadays, both pre-transplant as well as post-transplant. I think my previous speaker, Dr. Rakesh, has covered on a brief regarding minimal residual disease. I would like to touch upon that minimal residual disease here. And apart from these three indications, we do have flow cytometry usage in characterization of immunogenic reconstitution, diagnosis of chronic GVHD or acute GVHD, and we have other indications like diagnosis of viral infection, early detection of engraftment and graft failure, and also detection of alloimmunization of various blood cells, and also diagnosis of graft versus leukemia effect. So the first four indications I would be covering in detail, and the other four indications, because they are not routinely used, I would be leaving them. So first indication is the quantification of hematopoietic stem cells in the graft, that is harvest. This is the most important usage of flow cytometry, and because the quantitative and qualitative quantification of hematopoietic stem cells has revolutionized how we do BMT. Because the number and function of hematopoietic stem cells in the graft usually are more critical in achieving graft. And the quantity of hematopoietic stem cells in the harvest or graft is a reliable predictor of engraftment in many modalities of hematopoietic stem cell transplantation. That is, especially in matched siblings, this might not play an important role, but in matched unrelated donor or haploidentical donor or autologous stem cell transplantation or cord blood transplantation, the quantity and quality of hematopoietic stem cells is very, very, very important. And that's where the importance of flow cytometry comes here. And flow cytometry also tells us how many sessions of harvest we need to do by quantifying the stem cell amount in the graft. And so that we can use or we can infuse optimal dosage of hematopoietic stem cells. So by infusing optimal doses of hematopoietic stem cells, we can reduce the incidence of graft failure and also improve the outcomes of bone marrow transplantation. So what is the optimal dose of hematopoietic stem cell transplantation in different types? How do we decide? It depends upon the type of transplant we are doing, whether it is matched related or matched unrelated, or whether it's haplotransplant, or are we doing transplant in a benign setting, or are we doing transplant in the malignant setting? And also it depends upon the type of malignancy which we are doing for. And these are the few recommended doses by EBMT. The minimal requirement, minimal CD34 positive hematopoietic stem cells that are required for engraftment are 2 into 10 to the power of 6 cells per kg. So this is, we are talking about recipient's weight. And however, the optimal dosage most of us are comfortable with are ranges from 3 to 5 into 10 to the power of 6 cells. And because of, if you infuse optimal dosage of hematopoietic stem cells, the engraftment with the neutrophils and platelets would be faster, and the hospital stay would be lesser, and also the cost of transplant would be lesser. We have a subset called super mobilizers, where the harvest would yield an hematopoietic stem cell to an extent of 8 to 10, 10 to the power of 6 cells. And we are not sure whether infusing such a huge amount or large amount of stem cells would benefit the patient. In fact, infusing such a large amount would lead to increased GVHD in clinical practice. So the optimal doses would be 3 to 5 into 10 to the power of 6 CD34 positive stem cells. In cord blood, it's not just CD34 cells we look into. We also look at total nucleated cells. The recommended total nucleated cells in the cord blood are 3 into 10 to the power of 7 cells per kg, and CD34 positive cells are ranges from 1 to 1.7 into 10 to the power of 5 per kg. Tandem transplant we usually do in case of multiple myeloma, and for each transplant we need at least 2 into 10 to the power of 6 cells per kg. So these are the few recommended dosage or optimal dosage of harvest, the hematopoietic stem cells which we need to be there in the harvest before infusion for optimal grafting and reduction of bone marrow failure. So next, moving on to the second most important indication, that is measurement of CD34 positive hematopoietic stem cells in the peripheral blood. This is again a very important factor, because hematopoietic stem cells expresses CD34 on their cell surface, and these cells which expressing CD34, they circulate in a very small quantity or very small amount in the peripheral blood. So by technique called mobilization, whether by using filgrastim or chemomobilization, we increase the number of hematopoietic stem cells in the peripheral blood. And by measuring the amount of CD34 in the peripheral blood, we can estimate what is our harvest going to be, how much stem cells we are going to yield in the harvest. This is a surrogate marker for the harvest, how much amount of stem cells we are going to yield in the harvest. So we don't, because by doing this, we will be able to time the optimal timing when to do harvest, and we can also reduce the number of harvests by introducing something like Prelixafor if the peripheral CD34 counts are less than 20. Usually we recommend leukapheresis when peripheral blood CD34 count is more than or equal to 20 per microliter. And so suppose based upon this peripheral blood CD34, this is how we proceed in the clinical practice. If peripheral blood CD34 count is more than 20, then probably the harvest would be good. So we straight away go ahead for leukapheresis. But if the counts are less than 10, then probably our harvest is going to be bad. Then we employ other methods like preemptive Prelixafor, which is again a mobilizer, so that we can improve our harvest. And if the counts are somewhere between 10 to 20, then depending upon the indication and depending upon the center, depending upon the protocols, whether we can go straight away for harvest or we can employ Prelixafor administration for improving the harvest. Now moving on to immune reconstitution, which is a very important and very complex process that happens after transplant, in the setting of a transplant after hematopoietic stem cell infusion. So knowing about flow cytometry might not be routinely used in evaluation of immune reconstitution in bone marrow transplantation. However, flow cytometry has done a great job in understanding the process of post-transplant. That is, what is the process of engraftment, what happens in the engraftment, what happens, to understand the pathophysiology of GVHD, flow cytometry played a very, very important role. And flow cytometry can also predict whether the patient will have a viral infection or not, whether the patient will have a GVHD or not, whether the patient will have a relapse or not. So these are the few parameters where we can employ flow cytometry in diagnosis of these conditions. And flow cytometry can also be used in early detection of subtle signs of myeloid engraftment before clinically evident myeloid engraftment. So by doing this, we can tell which patient is going to recover, which patient is not going to recover, where we have to employ GCSF, where we don't have to employ GCSF. And we can also detect graft failure or recurrent disease at an early stage by using flow cytometry. So this was one study which has shown that in those patients who have graft failure, will have a defective expression of CD25 on the activated CD8 T cells. So yet another study has also shown that the monitoring CD34 positive cells post-transplant has correlated with the platelet recovery. So these are the few points where we can employ, these are subtle points where we can say that whether the patient is going in the right path or whether the patient is going to have complications by using flow cytometry. But we are not using flow cytometry routinely in the clinical practice for understanding this immune reconstitution because the amount of cells we get after transplant are very, very less, and there will be a lot of functional abnormality in the cells which we get immediately after transplant, and we don't have any standard methods to assess. That's the reason we don't routinely employ this flow cytometry in the post-transplant setting. Diagnosis of GVHD at an early stage is another indication which we can be use flow cytometry, because acute GVHD remains one of the major source of morbidity and mortality in allo BMT. We all know that. And we often detect GVHD when patient presents with clinically overt symptoms. And flow cytometry sometimes, if we use wisely, can help us detect GVHD at an early stage, and we can instill or we can treat GVHD at an early stage to prevent severe complications. So one study has shown that there is an increased expression of CD30 positive CD8 T cells in those patients who develop acute GVHD. And also the plasma levels of soluble CD30 levels are also much higher in patients who develop acute GVHD than those patients who doesn't develop. So for example, in this study, the median soluble CD30 levels were 62 nanograms per ml versus 17.4 nanograms per ml in those patients who develop acute GVHD and those patients who doesn't develop acute GVHD. And by biopsying the affected organs, even in those organs, there were increased number of CD30 positive infiltrating lymphocytes by IHC. So this was a study which has evaluated role of CD30 in diagnosis of acute GVHD. And this was by Chen et al. And this table clearly shows that this is those patients who have developed GVHD, and this is those patients who didn't develop GVHD. These are the T cell subsets, all CD4 and CD8. So there was no difference in CD4 subset. However, in CD8 subsets were seen more in number in patients who developed GVHD. We can say especially central memory CD8 positive T cells and also effective memory CD8 positive T cells. So another trial, this was published in the Blood. This trial has shown that there is an expansion of T memory stem cell-like cells at the onset of acute GVHD when compared to patients who didn't have a GVHD. These are the plots where we can clearly appreciate this is increased T stem cell-like cells in the patients who have acute GVHD. On molecular profiling of these T cells, there is the results have shown that there is a decreased TGF-beta and also increased NF-kB signaling in these cells. So this is quite a bit complicated. I don't want to enter into this topic now. So now moving on to the other ones, the role of MRD testing. As Rakesh has briefly described about role of MRD, which is gaining importance in nowadays, especially in hematological malignancies. And again, the timing of MRD in the setting of hematopoietic stem cell transplant is debatable. Some authors say whether we have to do bone marrow MRD before transplantation, and some authors say MRD post-transplantation is important. However, some studies have shown that MRD positivity prior to transplant has shown to have a poor survival outcomes and also increased leukemic recurrence and also the increased non-relapse mortality in those patients who have MRD positive before transplant. And some other trials have shown that there is no difference in survival benefit whether the patient have MRD positive or negative before transplant. But I'm not going to details. But one thing is that flow cytometry can be used before transplant to assess MRD in these patients. And even in patients with post-transplant, if the patient has MRD positive after transplant, there's definitely increased risk of relapse or recurrence of the disease. We can see that there is 80 to 100% increased risk of relapse in those patients if the MRD is more than 10 to the power of -3. And also, the timing of assessment of post-transplant MRD is also again debatable, because if you do MRD within 100 days, there's a lot of interference with acute GVHD. If the patient develops acute GVHD, then the assessment of MRD could be a little bit of dicey and a little bit of difficult. So exact timing of MRD determination in patients post-transplant is also a debatable question. So moving on to the other important topic, that is graft manipulation, which we often do in the setting of allotransplant in case of unrelated transplant or haploidentical transplant to reduce the incidences of GVHD. In those patients, few of the manipulations which often we do are CD34 enrichment and depletion of CD3 and CD19 cells, and also depletion of TCR cells and CD19 cells. By doing this, we'll be able to reduce the contamination with the T cells and B cells, which are mainly responsible for occurrence of GVHD. So for sorting out of these cells, we need flow cytometry. So the technique is slightly different from the normal flow cytometry which we do. Nevertheless, flow cytometry is an important parameter or important tool in determining these cells. And to summarize, flow cytometry is an indispensable tool in hematopoietic stem cell transplantation. The role of flow cytometry is very, very important, starting from detection of peripheral blood CD34 positive cells and also determining the quantity and quality of hematopoietic stem cells in the harvest, and also pre-transplant MRD, post-transplant MRD, and it is also used to detect certain viral infections. Earlier they used to use to detect for CME virus, herpes, HSV virus, but nowadays we have other tools to detect these viruses. We don't employ flow cytometry in detecting these viruses. And nevertheless, I feel that flow cytometry is underutilized in bone marrow transplantation. We are hoping to, more and more studies will come up where we find usage of flow cytometry in hematopoietic stem cell transplantation, so that we can reduce graft versus host reaction, and so that we can increase the engraftment and increase the outcomes of bone marrow transplantation. With this, I would like to conclude my trial, my presentation, and thank you, Dr. Upendra sir, for giving me this role.
Thank you very much. That was really indeed a beautiful presentation, especially the way the entire spectrum was covered right from the inception, where you're taking CD34 positive stem cells as a graft, even as a monitoring tool when you're trying to go for harvesting also. Beautifully presented. And in fact, the entire spectrum has been covered beautifully. Just one comment I would like to make, considering that haplotransplants have started coming up in a big way, a lot of people would also like to do flow cytometric cross matches. This is another thing which has come up. Of course, kidney guys are always doing flow cross matches aggressively in their routine practice. And because of haplotransplants, a lot of people have started using flow cross match also as one of the activities. Any questions? I throw it open to the audience. No questions. So thank you very much. I think that was a beautiful talk, and kudos to you. Thank you.
Thank you. Thank you, sir.
I request Dr. Anil Handu Garu to present a token of appreciation to Dr. Ramavat Garu. Thank you, sir. I request Dr. Ramavat Garu to present a token of appreciation to Dr. Anil Handu Garu. Thank you, sir. Moving on to our next session, which is on interesting flow cytometry cases by Dr. Maithili Garu. I would like to request Dr. Upendra Srinivas Garu to please come over and chair the session and kindly introduce Dr. Maithili Garu. Welcome, sir. Welcome, ma'am.
Then went on to do her DNB from Sir Gangaram Hospital, New Delhi. And she's been blessed with a lot of awards. With one premium poster at Indian Myeloma Congress and runner-up in All India Hematology Quiz. Over to you, madam.
Good morning, everybody. Thank you very much, Dr. Upendra Srinivas sir, for giving me this opportunity to present this interesting flow cytometry cases. And I congratulate you, sir, for organizing such a wonderful CME and hands-on workshop. So I'll be discussing few interesting flow cytometry cases. This is a case of a 39-year-old female. She presented with generalized weakness, fever of 2 weeks duration. And on examination, there was pallor, gum hypertrophy, and cervical lymphadenopathy. Complete blood counts showed hemoglobin of 6.8, total counts of 26,000, and platelets of 54,000. Bone marrow that was done showed these abnormal looking large cells with prominent, abundant granular cytoplasm and prominent nucleoli. On cytochemistry, the MPO stain was negative, and non-specific X-ray stain was positive. So we went ahead with flow where the blast population was gated, and these blasts showed 13 positivity with 33 positivity. CD7 was negative, and HLA-DR and CD117 was positive. CD11B was positive and CD15 was positive. CD14, CD64 being monocytic markers were positive. There was heterogeneous positivity for CD14 and bright positivity for CD64. And the 14 and 64 markers being more specific for monocytic cells, the diagnosis was acute myeloid leukemia monocytic, that is AML M5. The next case is a 53-year-old female. She presented with fever and generalized weakness. CBC had pancytopenia with hemoglobin of 7.6, TLC of 1800, and platelet count of 30,000. Bone marrow was particulate and cellular with these abnormal looking cells that had high N/C ratio with prominent nucleoli. MPO staining was negative. So this population was gated, and these populations showed CD22 positivity, CD5 was negative, and CD20 was positive. So CD20, CD22 being positive is a marker of lymphoid series, and these blast population was CD7 negative, CD13 and 33 were, CD33 was negative, but CD13 was positive. CD13 is a myeloid marker again. CD7 was negative, HLA-DR was positive, CD33 was negative, CD13 positive, and finally this patient turned out to be BALL with aberrant myeloid expression. In BALL, usually CD13, CD33 and CD25 show positivity. So this was a case of BALL with aberrant myeloid antigen expression with pH positivity, sorry. This is a case of a 32-year-old female. She had a history of bleeding rectum and bleeding manifestations, bleeding PV since a week of duration, and presented with generalized weakness. CBC showed pancytopenia, and bone marrow revealed hypercellularity with presence of abnormal cells. These abnormal cells on flow, there was increased population with high side scatter. High side scatter indicates granularity, high side scatter, and this flame shaped picture on the side scatter versus CD45 is more specific for promyelocytic leukemia. These promyelocytes, these abnormal gated population was positive for MPO. It was negative for CD3. It was positive for, it was negative for CD7, that is T cell markers, negative CD34, this is an important marker in promyelocytic leukemia, and CD79A B cell marker, and 19 is negative. So these cells showed CD13-33 positivity indicating myeloid series, and 64 was positive. CD14 was dim positive, and CD117 was negative. This was a case of the other markers like 15, CD15 was weak positive, CD56 was negative, and CD123 was positive. This was a case of acute promyelocytic leukemia. The next case is a case of a young female. She presented with breathlessness, and she had a mediastinal mass. On bone marrow aspirate showed increased presence of these abnormal looking cells with high N/C ratio with prominent nucleoli, and this special stain is acid phosphatase stain. This acid phosphatase stain is usually positive in T cells. So this was a suspected case of T cell ALL. So coming to the flow, these cells were positive. The gated cells were positive for CD3, negative for MPO, and CD7 was positive. CD34, 19, 79A and MPO were negative. Further markers like CD3 was positive, CD4 was dim positive, CD1A was negative, CD99 was positive, CD5 was dim positive, CD4 was dim positive, and CD8 was positive. So this is a case of T cell ALL along with T cell markers being positive and B cell and MPO being negative. This is commonly encountered situation that a 65-year-old male asymptomatic on routine health checkup has isolated lymphocytosis and hemoglobin and platelet counts were normal. Total counts were 1,28,000. A peripheral smear showed these mature looking cells which had clumped chromatin and a few showing nucleoli. And bone marrow showed increased cellularity with replaced by these abnormal looking lymphocytes. So on for flow cytometry, these gated population was CD19 positive, CD20 positive, indicates B cell lineage, and CD5 was positive, CD10 was negative. The other markers, CD23 was positive, FMC7 was negative, CD3 was dim positive, and CD38 was dim positive, and there was kappa restriction. So this indicates clonality, and this is a case of chronic lymphocytic leukemia, and in this flow also helps us in prognosticating the CLL patients. CD38 is an important prognostic marker, and more than 20%, if there is expression of more than 20% of CD38 positive cells, it indicates poorer prognosis in CLL. And this patient further went ahead for FISH analysis and karyotyping, and he had trisomy 12 and deletion of 13q positivity. The next patient is a 60-year-old male. He presented with complaints of fever of 1 month duration and progressive fatigue. On examination, he had spalar and splenomegaly was present up to 3 centimeters below the left costal margin. CBC showed pancytopenia, hemoglobin of 6.3. TLC of 2,150 and platelet counts of 18,000. On peripheral smear, we can see these abnormal looking lymphocytes which have few small hair-like projections around, surrounding the cell. And the bone marrow was replaced, there was an increased population of these abnormal looking lymphoid cells. And on bone marrow biopsy, there is a prominent honeycombing pattern that is seen in these cases. This is a case of hairy cell leukemia, where flow helps us in diagnosis also. So this population, the purple color population, it is present at the which has a little higher side scatter as compared to the normal mature lymphocytes. And these population was CD19 and 20 positive, and this was lambda negative. So and 11C was positive in this in these populations. CD25 and 103 were positive. So this is a case of hairy cell leukemia. So flow, as Dr. Ramesh has clearly elucidated about the importance of flow in CLPDs. So it gives us an easier picture to diagnose the CLPDs. CD10 positive, CD5 positive, CD10 negative. This we can think of chronic lymphocytic leukemia, mantle cell lymphoma, and pro-lymphocytic leukemia. CD5 negative. If it's CD10 positive, then follicular lymphoma, DLBCL or Burkitt's lymphoma can be a possibility. Both CD5 and CD10 negative indicate marginal zone lymphoma or hairy cell leukemia. So BCLPDs with CD19, CD79A and CD22 positive, they are B cell markers. So it is a B lymphoproliferative disorder. Then we see for CD5 positivity. If CD5 is positive and CD23 is positive, both positive, it is a chronic lymphocytic leukemia. CD5 positive, CD23 negative, it is mantle cell lymphoma. There we have cyclin D1 positivity. CD5, if it is negative, then we see CD10. If CD10 is positive, it could be follicular lymphoma, DLBCL or Burkitt's cell lymphoma. CD5 positive with hairy cell markers that are 11C, CD11C, CD103 and CD25. This indicates a diagnosis of hairy cell leukemia. Also, flow helps us in differentiating different presence of lymphocytosis with splenomegaly with presence of villi in the hair-like projections in the lymphocytes. The differential diagnosis could be hairy cell leukemia variant, or splenic lymphoma with villous histiocytosis. Villous lymphocytosis. And how we differentiate by using flow is using these three markers, CD103, CD25 and CD123 and 11C. So 11C being positive, CD25 being positive and CD123 being positive along with CD103 positivity indicates a diagnosis of hairy cell leukemia. In hairy cell leukemia variant, CD25 and CD123 both are negative and 11C is positive. In splenic lymphoma with villous lymphocytosis, CD11C is also negative along with CD25 and CD123. So all the markers are negative in splenic lymphoma with villous lymphocytosis. So this we have dealt with cases where flow cytometry helps in the diagnosis of acute leukemias and chronic lymphocytic disorders, lymphoproliferative disorders. We'll see one case that where flow cytometry helps us in a diagnosis of primary immunodeficiencies. This case has come recently, 1 week back. He's a 11-year-old boy who presented with fever, weakness, cough and breathlessness, yellowish discoloration of sclera 1 week before admission. On investigations, he had anemia, he had indirect hyperbilirubinemia, he had massive hepatomegaly, he had a cervical lymphadenopathy and a splenectomy scar also. So his past history was very significant with jaundice and anemia since day 1 of life, along with thrombocytopenia and progressive splenomegaly. Splenectomy was done at the age of 3. And since 2 years, he was having recurrent increased frequency of transfusion with cervical lymphadenopathy, biopsy showing necrotizing lymph nodes, and he received antibiotics, but there was no improvement. G6PD levels were done at the time of admission 2 years back, and it was labeled as G6PD deficiency, but the cervical lymphadenopathy could not be explained by this G6PD deficiency. 3 months back, he was admitted at CMC Vellore with bilateral pneumonia, lymphadenopathy, hemolytic anemia. There was a suspicion of tuberculosis and ATT was started, but there was no improvement. We had a suspicion of autoimmune lymphoproliferative syndrome, seeing the sequence of his events. And for a diagnosis of ALPS, that is autoimmune lymphoproliferative syndrome, we have one criteria, that is chronic lymphadenopathy or splenomegaly of more than 6 months duration, that is non-infectious and non-malignant. And elevated double negative T cells are a classic marker for this disorder, and elevated double negative, that is CD3 positive with CD4 and CD8 both being negative. Normal people have less than 1.5%, but when it's elevated, that is more than 1.5%, it comes as a required criteria for diagnosis of ALPS. This patient had autoimmune cytopenias, and he also had elevated vitamin B12 and immunoglobulins also. And these are secondary criteria, and ideally we require NGS to confirm the diagnosis for the mutations of FAS and FAS ligand and Cas10 mutations. And this was the flow cytometry that was done, and this population, CD3 events were 63% with CD8 and CD4 positivity 44 and 9% respectively, and both double positive were 0.75. So CD3 positive with CD4 and CD8 both being negative constituted 8.24% of total lymphocytes. So this aids in a diagnosis, and ideally he requires a NGS panel to be done. Thank you so much.
Thank you, madam. That was a really excellent presentation with a lot of cases. You have not left anything. I think you covered entire spectrum of cases that we have to see today. Indeed, a great presentation. I think with the last case that you have set the stage ready for the next very, very special session, which is going to be on the primary immunodeficiencies with one of the best and top-notch speakers on the subject matter that we have in the next session. And thank you very much for that. And if you have any short question.
Thank you.
As we're already running late. Yes, sir, go ahead.
I want to ask you a general question to you and to Srinu also. Has anybody heard what is called a blunderbuss?
Sorry?
Blunderbuss.
Blunderbuss?
Blunderbuss therapy.
Blunderbuss?
Yes.
Not really, sir, I admit.
A blunderbuss is a gun, retort gun. You fire it, it gives you about 100 bullets, 100 pellets. They go and hit somewhere. So, in fact, we used to do in in the statement, in the initiation of ATT also, you call it blunderbuss therapy. Similarly, what you find in all these things, all these immune markers is, you have a set of markers. You fire about 100 markers, and some of them hit, and by exclusion, by inclusion, and you come to the diagnosis. Is there any way this total blunderbuss number is reduced so that you can arrive at a particular specific diagnosis with the least number of bullets in them? You got my point?
Yes, sir. Yes, sir.
Well, adding 100, the CD3 positive, these two are negative, these two are positive, it's all by question of exclusion. Can you limit this particular?
Yes, sir.
I'm glad that you are willing to take that kind of question. It should be directed towards us.
So when we do flow cytometry, first we run, if it's a suspicion of acute leukemia, we run an A-lot tube, sir, which has basic markers initially. It has T-cell markers, B-cell markers, and myeloid markers. And depending on the positivity of the first tube, then we run the other specific tubes, sir. There be lymphocytic tubes, ALL tubes, AML tubes, and depending on the positivity, sir. So it is done sequentially. It is not that it is done at a one step. It is done in a sequential basis, sir.
My take on that question, sir,
Thank you,
because as a pathologist and a hematologist, I would be the most happiest if I have a limited set of markers to make the diagnosis. But flow cytometry is a very, very evolving science, and it's not going to reduce that parameters in the near future at all. Take it from me, it's not going to happen. Because out there in the world, there are a lot of flow maniacs. They do a lot of flow work with a huge volume of different repertoire of cases at their institutes. Their job is to get deeper and deeper into decoding the entire immunophenotyping of these cells. It's that data and that blunderbuss is not going to go away anytime in the near future. With that, thank you, madam. And I think we should move to the next session now. I'll assume the role of...
I request Dr. Upendra Srinivas Garu to present a token of appreciation to Dr. Maithili Garu.
Now we move on to quickly the pre-lunch. The last session, which is a very, very special session. That's the reason why I've come to assume this role. This is, in fact, the whole topic today has been about the hematological malignancies and role of flow cytometry in that. But now I would all want your attention to a very specific topic and a very specific and a very highly erudite speaker that we got from prestigious National Institute, whose volume day in and day out is primarily on primary immunodeficiencies and immunopathology, and his area of interest is transplant immunology. For that session, sir, I would like to call upon Dr. Radhakrishna sir, who has been my teacher, and he will be teacher for my rest of my life, and who taught me actually a medical logic. I am indeed grateful to him, and today that he is there for chairing this session. Sir is a chief pediatrician in Omni RK hospitals, and then he is recently been elevated to a vice presidentship in Indian Association of Pediatrics. Sir, over to you. The speakers,
Thank you. Good morning, one and all. Many times it's always a doubt, who is a bigger beneficiary, the lab or the consultant? Let me tell you, today CMC value is that big spot because they have got a good microbiology, good pathology, good biochemistry. 1981, I was a house surgeon in Andhra Medical College. We had a very difficult case. There was a case admitted in Department of Dermatology. So the adult had a dry skin, reddish, scaly lesions. The dermatologist did not understand the diagnosis. They took a small bit. They said it was a skin biopsy, send it to pathology. I was the house surgeon. After 7 days, I brought the report. They sent the biopsy with the diagnosis of KUO. So I brought the report and told our dermatologist, sir, it is the pathologist has given the report as there was increased edema, there were infiltration. Diagnosis consistent with KUO. Our dermatologist got ragged up and went to the Department of Pathology and questioned them, what is this report? The pathologist said, you made a diagnosis of KUO. We gave the diagnosis of KUO. He said, I made a diagnosis of kept under observation. Okay, there's nothing like KUO. So that is the many times our quality of reports. So if the Department of Pathology, Microbiology, Biochemistry is wonderful, we are the biggest beneficiaries. We do not have cases of primary immunodeficiency. When I was a student in 1980s, we thought we did not have. What everything given in Nelson was bullshit. No, if I see 20 cases of sickle cell anemia, the incidence of primary immunodeficiency is same. I should be seeing 20 cases of primary immunodeficiency per year. So 1999, when I went to Mumbai for a conference, Dr. Desai was speaking on primary immunodeficiency. Then after that, he was telling me, he told about B cell deficiency, T cell deficiency. I said, how do we count the B cells and T cells? Then he told us, B cells means CD19, T cells means CD3, all these things he told us. Then we started sending workup for immunodeficiencies in Visakhapatnam. Probably I'd seen 15 or 20 cases of SCID in the last 20 years. Service, Dr. Biman, who is a professor of immunopathology from PGI Chandigarh, is going to talk about these immunodeficiencies. He has got wonderful publications. To you, sir, Professor Biman Sekia.
Good afternoon, everybody, and thank you, sir, for that kind introduction. So I'm the odd man out today. Actually, all are hematologists here. Thank you. So yes, I know I'm wading into an unfamiliar territory, and that's why I asked Srinivas to give me 1 hour at least to cover the topic. Before I start, I have a few disclaimers that I'm not a flow cytometry expert. Like Dr. Manu and Dr. Handu, they're sitting there, they're technical experts. A lot of they do flow cytometry in and out, and I'm basically a pathologist, but I love to teach, and that's what I'm going to do today. So I'm going to talk about the role of flow cytometry in primary immunodeficiency diseases, and at the end of the talk, I'd like to pass on this message that you need very simple tests to diagnose primary immunodeficiencies. It's not a very high funda kind of science here. So small tests and big clues, that is the theme of my talk. And it's a very rapidly evolving science, and you'll realize that the number of disorders that are described today are advancing at a very rapid rate, and a lot of newer molecular defects and newer diseases are added on every year. And what we call primary immunodeficiency diseases is now called inborn errors of immunity. So that's the latest terminology, and we no longer call them PIDs, because when you call them PID, the gynecologists used to have a lot of problems, because PID is pelvic inflammatory disease. So when you say PID, they get confused. So immunology is simple. This is how it looks like. There are a lot of cells, and there are a lot of molecules, there are a lot of interactions that happen. And it's very difficult to decipher everything that is immunology, but still the science of the immunology has okay. There's something wrong? Okay. Hello? Okay. I can, okay. So we'll try and understand a little bit of this complex scenario here. And we'll discuss a little bit about the basics of immunology, because that will make it easier to understand what these diseases are. So we know that immunity can be innate immunity and adaptive immunity. And in innate, we have the innate cells like all the granulocytic series and the dendritic cells and all. And in adaptive, we have the T cell and the B cell. And there's a lot of crosstalk between this innate and the adaptive wings of the immune response. And these two systems are not in isolation because innate immunity it is critically linked to the adaptive immunity, and the adaptive cannot come without the innate immunity. These are basic concepts of immunology which we are all familiar with. So the International Union of Immunological Societies, the IUIS, is the primary organization that classifies these diseases. And the 2017 was the last classification that had come, which had 354 disorders that were included in the IUIS classification 2017. And the latest classification is due in 2022. It's going to come very shortly. But it's evolving so frequently that in 2017, when this report was made in February, there were 354 disorders. And now this in 2019, there was an update given. It increased to 430. And the primary immunodeficiencies, or the IEIs, are classified into these 10 categories. Combined immunodeficiencies, combined means both T and B cells are involved, which includes the severe combined immunodeficiency, or the SCID, and the combined immunodeficiency with generally less profound. Then we have the other categories like CID associated with syndromic features, predominantly antibody deficiencies, diseases of immune dysregulation, congenital defects of phagocytes, and all these 10 categories we have. So we all have this notion that primary immunodeficiencies are very rare, and that's why we don't care to know about this. So they may be uncommon, but they are not rare. And as Sir has already alluded, that he has already seen so many cases of SCID lately. So it's not at all rare. It's uncommon. We see it uncommonly. If you see the data, it's 4 times more common than hemophilia. Everybody knows about hemophilia. It's approximately 5 times more common than cystic fibrosis. Is twice common as childhood leukemia and lymphoma combined. If you take PID as a group, it's much more common than what we are actually talking about now today here, the leukemias and the lymphomas. And there are warning signs in children and adults which are very similar, and I'll deal with them one by one. And they often present with very common clinical symptoms. And obviously, it's because it's an immune defect, so infections are the predominant findings. And when we talk of PID, we talk of infections mostly. But many of these patients can also present with autoimmune diseases, like a full-blown SLE. A 1-year-old boy presenting with full-blown lupus is also a PID. So both the things are there. And even malignancies. Many of these patients can present with malignancies. So infection is just one part. We have autoimmunity and we have malignancy also in the spectrum of the primary immunodeficiencies. Now, when you talk of primary immunodeficiency, we have to look at three basic things when you were evaluating a patient. The age of presentation, the type of organism that is involved, and the family history. These 3 are very basic things that you have to give importance to when you're evaluating a patient with primary immunodeficiency. Because 40% of the PIDs are diagnosed in childhood, in the first year itself, because it's mostly a pediatric kind of a problem that we have here, and another 40% will be diagnosed by 5 years. So the prevalence of these disorders in childhood is basically because these diseases are severe and they present very early. That's why. But there are diseases which are milder, and the patient can present in late adulthood because they are milder diseases. So most of these diseases will present within the first year or the first 5 years of life. And Another important thing to realize is the disease of onset is, most of the T cell defects and the phagocytic defects, because they are severe defects, they will present within the first 2 to 6 months of life. Yeah, okay? Whereas the antibody defects or the B cell disorders, they present later, because within the first 6 months of life, the child is protected by the maternal antibodies. Okay? So only when the maternal antibodies, they wane off gradually, and by end of the first year, all the maternal antibodies would have disappeared. And if the child's B cell response has not taken up in the B cell disorders, then this child will start presenting after 6 months. So remember this point, if the baby has presented before 6 months or the early first year of life, it's most likely the problem is in the T cells or the phagocytes. And if it is after 1 year, it is the B cell or the antibody deficiencies that we can think of. Okay? So these are a few basic concepts. Now, I'll now talk of a few basic immunology things. So we have the T cell, we have the B cell, we have the phagocyte. Okay? The phagocyte or the antigen-presenting cells, they're component of the non-specific immunity or the innate immunity, and we have the T cells and the B cells, which are components of the adaptive immune response. Now these are interlinked, they're crosstalk, okay? Because it's the APC which captures an antigen and presents it to the T cell. So the T cell will respond only when the antigen-presenting cell has presented the antigen to the T cell, okay? So it's dependent on the APC, obviously. And the T cell then produces a lot of cytokines and things which again stimulate or activates the antigen-presenting cells. So that's how it works. And also, the T cells will produce a lot of cytokines and things which activates the B cell. The B cells are totally dependent on the T cells, okay? If there are no T cells or the T cells are non-functional, so even if the B cell numbers are normal, the B cells are non-functional. So remember this point, that B cells are always dependent on the T cells, okay? It's like tere bina hum bekar. So T is tere and B is bekar. So without T, there is no B. The B cannot function without the T cells, okay? Now these cells, they have certain functions. When you talk of infections, the macrophages or the phagocytic cells are very important to handle catalyst-positive bacteria and fungi. The B cells, because they primarily act through the antibodies, they are responsible for handling extracellular pathogens, like extracellular bacteria. And the T cells playing the center role there, they are important for viruses, bacteria, as well as fungi. So when these components are missing somewhere, then we can expect what kind of infections the patient is going to have. If it's a defect in the phagocytes, the most of the organisms that will be involved are catalyst-positive bacteria like staph, Serratia, Marsinus, Klebsiella, and all this Cepacia and all these things. And this is the typical spectrum that we see in chronic granulomatous disease, which is a phagocytic defect. Because the phagocytes are involved in handling these kind of pathogens, that's why when the phagocyte goes wrong, these are the kinds of infections that we're going to have. So looking at the spectrum of infections, you can actually make a guess which cell has gone wrong, okay? Similarly, the complement defects, the typical organism is the pathogenic bacteria and specifically Neisseria. If you see Neisseria meningitis, in a very severe Neisseria meningitis in a child, you can think of the complement defects, okay? It's so specific. The early complement defects will present like lupus, and the late complement defects, they present with Neisseria meningitis, okay? And similarly, in the T cell defects, now T cell defects is like HIV, if it's the CD4 cells are not there, you get a lot of everything. You can get bacteria, fungi, viruses, everything. So T cell defects, there's a lot of organisms, everything basically. Whereas in the B cells, again, I told you it's the extracellular pathogens that the B cells take care of by producing antibodies. So you get a lot of staphylococcal and streptococcal and hemophilus kind of infection. And Also enteroviruses. Okay, enteroviruses are very important organism, and mycoplasma. B cell defects, staph, Haemophilus, okay, the enteroviruses and the mycoplasma infections. A lot of patients of B cell defects, I'll come to it later, X-linked A gamma globulina patients present with mycoplasma arthritis. They will go to the rheumatologist, and they'll be treated with steroids because they are presenting with arthritis, but the mycoplasma goes undetected because mycoplasma is very difficult to pick up in the routine investigations. So mycoplasma infections. So what I mean to say is, but just by looking at the spectrum of infections that's happening in a particular patient, you can make a guess which cell or which wing of the immune system has gone wrong. Okay? Now, let's talk of this system first. We have the macrophage. We have a small toll-like receptor that's sitting on its surface. When there's a pathogen, that toll-like receptor will recognize the PAMPs or the pathogen-associated molecular patterns, and the phagocyte will get activated because of the TLR signaling to the TLR. Okay. So the TLR here, you can see that toll-like receptor that's sitting there, and we have the downstream molecules like MYD88, and the second system is so this is the first system that's there in the phagocyte, the TLR system. The second system is the NADPH oxidase system, which is involved in the respiratory burst of a phagocyte. Okay, so this enzyme NADPH oxidase has different components like the GP91, the P22, the P67, P47. So these are subunits of the enzyme. When the phagocyte gets activated, all these components come together to the membrane of the phagocyte and then becomes the active enzyme, and the cell then produces hydrogen peroxide. Okay, that's how the pathogen is taken care of. The third is the phagocyte produces interleukin 12. It stimulates the T cells because it has IL-12 receptor sitting there, and then the T cell produces interferon gamma, and that interferon gamma in turn stimulates the phagocyte because the phagocyte has the interferon gamma receptor. So this is a vicious cycle that happens, the phagocyte stimulating the T cell and the T cell stimulating the phagocyte. Now this is very important in handling, and the last system is the complement, okay? Now, these stars basically indicate genetic defects that can happen. So these stars are basically patients. So you can see patients of all these molecules. The TLRs can be defective, the integrin beta 2 can be defective, the NADPH oxidase system, the entire system can be defective, and the IL-12 receptor, or the interferon gamma, or the interferon gamma receptor, all these things you can have mutations in these molecules, okay? So if there is, for example, the defect in the MYD88 or the TLR3, now the TLR3 defect is these patients, TLR3 defect patients, can handle everything except HSV, herpes simplex. They cannot handle HSV. So TLR3 defect patients will present with herpes simplex encephalitis. It is so organism specific. It's so specific. So TLR3 defects, the patient will have herpes simplex encephalitis, okay? MYD88 defects, they will have early pyogenic infections because the phagocytes are not getting activated because the TLR is not working. The other thing, the NADPH oxidase system, if it has gone wrong, the patient will have chronic granulomatous disease, okay? So the defect can be anywhere. It can be in the GP91, the P22, P47, P67, anywhere. Now GP91 is an X-linked disease because that molecule is encoded in the X chromosome, and rest are autosomal recessive disorders. Okay, so GP91 is X-linked, so that gives rise to X-linked chronic granulomatous disease. And the fourth disorder I'm going to talk about is the Mendelian susceptibility to mycobacterial disease. Now, to handle mycobacteria, this IL-12 interferon gamma axis is very crucial. So if there is a defect in the IL-12 or the interferon gamma or its receptors, these patients, they cannot handle mycobacteria. they will have infections with non-virulent mycobacteria. If you give a BCG shot to these patients, he will have catastrophic BCG adenitis, and the BCG will disseminate and kill the patient. So this is called Mendelian susceptibility to mycobacterial disease. They get infections with environmental mycobacteria, which we normally handle. We normally handle mycobacteria, which is there in the environment. But these patients with IL-12 interferon gamma axis defects, they cannot handle mycobacteria. Okay, I'll show you some cases now. Now, let's first talk of the CGD, okay, and the role of flow cytometry in diagnosing the chronic granulomatous disease, which is basically a defect in the NADPH oxidase system. Now, DHR is a compound which is non-fluorescent, DHR123, dihydrorhodamine. So when you add this compound to neutrophils, and when the neutrophils get activated and produce hydrogen peroxide, that hydrogen peroxide will oxidize this dye and make it fluorescent. Now, this is a very cheap dye, and the reagents that you require to do this test is not at all expensive, and Upendra will agree with that. And it's a very simple test to do, and by which you can pick up these cases with chronic CGD. And CGD is not an uncommon disease. You'll encounter it in your daily practice, and I mean the pediatricians will agree with me. So the only thing, previously we used to do the NBT dye reduction test, which produces this black color if there's production of hydrogen peroxide. Now, let's take example of this 17-year-old boy presented with fever and shortness of breath and right upper abdominal pain. He had tender hepatomegaly, HIV was negative, CD4 count was normal. When you look at the immunoglobulin profile, he has hypergamma-globalinemia. It's increased. IgG is increased, A is increased, M is increased. So hypergamma-globalinemia he has. And the CECT and the MRI showed multiple hepatic abscesses. Now, when you see deep-seated abscesses, you have to suspect CGD. Okay? So this patient had hepatic abscesses. We did the NBT dye reduction. You can see that in the patient, in the panel to the left, there's hardly any black color. So the patient has not produced hydrogen peroxide. That's why the NBT dye reduction hasn't taken place. Where in the right side, we have the control. So the simple slide test, this is even cheaper. This is much more cheaper than DHR. So this will give an indication that the patient's neutrophils are not producing hydrogen peroxide. So you do a DHR, you can see the upper panel is the control. You can see when you get on the neutrophils and look at the DHR oxidation, you see that there's shift to the right, and this is a normal. Whereas in the patient, which is in the lower panel, you can see the shift is minimal. So, which means that the hydrogen peroxide production is not optimal, and that's why the shift has not, thank you so much, thank you. Shift to the right has not taken place. So, very simple test, very simple to do, and you just need some PMA to stimulate the neutrophils and the DHR, okay? So after that, you can do these, you can target, if you have an antibody towards those specific compounds, if GP91, the P67 and P47 that I was talking to, you can have antibodies so against that. So B558 is the GP91 FOX. So if you have an antibody to that, you can do the flow cytometry for B558, and you can see in the patient, in the lower panel, the shift is reduced compared to the control, which is in the upper panel. So there's reduced B558 expression. So the patient qualified for an X-linked CGD. Okay. Then you can go ahead and do the gene sequencing and confirm and have a molecular diagnosis. So simple flow cytometric tests, which gives you a clue to the diagnosis of X-linked CGD or what the other CGDs also. So this was a series of 236 patients that we published last February in Frontiers in Immunology. So this was a national data that we had published. We, kind of collaborated with all the centers that were seeing these patients and had the molecular diagnosis, and 236 patients were published last year. So we have these patients in our OPDs. The only thing is that we are not recognizing them. Okay, this is a family of DHR testing. You can see the first one is the test or the patient, where you see that there's hardly any shift to the right. The control is to the right. You can see that the shift to the right is there. The mother is a carrier because it's an X-linked disease, so you have two peaks in the mother, you can see, okay, lower left, and the father is normal. So the entire family you can see here, this is an X-linked CGD, where the child is, does not show any DHR oxidation, and the mother shows two peaks. That's because she's a carrier. Okay, see, so there's the same panel here. Upper panel, you can see the DHR, which is normal control, and the patient that you see there, which the mother is showing, patient is not showing any shift. The mother is showing two peaks, again, and it can then have flow cytometry for GP91 or the P47 or the P67, and then say which kind of CG this is. Another case here, there's a 3-month-old girl, and patient had omphalitis and large perianal ulcer. Most of the pediatricians will easily diagnose this. Look at the absolute neutrophil count, it's 60,000. Okay, it's very high neutrophil counts. And if you look at the abscess, in spite of being such a huge abscess, there's hardly any pus there. Why no pus? Because the neutrophils are not reaching there. This is leukocyte adhesion defect. Okay? The leukocytes are not reaching to the site of infection, so that's why there's no pus there. So if you look at the beta-2 integrin or the CD18 expression there, you can see that the CD18 expression is not there. So this is LAD type 1. So flow cytometry can give you a diagnosis of leukocyte adhesion defects. You can do a flow cytometry for CD18, and you see that there's hardly any expression in the patient of beta-2 integrin. That's why the neutrophils are not able to adhere to the endothelium and diabetes out and go out of the blood vessel and reach the site of infection. That's not happening because of the leukocytes are not able to adhere because of the defect in the beta-2 integrin. So beta-2 integrin defect giving rise to LAD. Okay. There's another 10-year-old boy presenting with fever for 1 month, loose stools for last 1 month, and born to a non-consanguineous couple. The child had BCG adenitis, okay, at birth after BCG. And the X-ray showed multifocal osteomyelitis-like disease with lytic bone lesions everywhere in the long bones. He had a lot of lytic lesions. So this is the typical scenario of MSMD. Okay, Mendelian susceptibility to mycobacterial disease. You get BCG adenitis and multifocal osteomyelitis. And we did the CD119 expression, which is the interferon gamma, because as I told you, the MSMD has a defect in the IL-12 interferon gamma axis. So interferon gamma receptor 1 was normal, and when you do the CD212 or the IL-12 receptor beta 1, and we saw that the CD212 was reduced in the patient. You can see only 1.4% compared to 33% in the control. So a reduced expression CD212, that is the interferon, the IL-12 receptor. And when you did the mutation analysis, we found a mutation in exon 9 of the IL-12 receptor beta 1 gene. So this is MSMD because of IL-12 receptor beta 1 deficiency. Another case, a 17-month-old boy, born preterm, and he had, left axillary lymphadenitis, again, BCG adenitis. And he got pyogenic meningitis at 9 months and hearing loss. And then at 17 months, he was admitted with all these history. Okay. Again, he had a lot of lytic lesions in the skull and the long bones. We looked at the CD119 expression, and you saw that the CD119 expression was low in this patient. So these are the clinical spectrum of patients that you get in the phagocytic disorders. Okay, I'm not touching upon the neutropenias, the congenital neutropenias and the cyclic neutropenias. As hematologists, you would all be familiar with those kind of disorders. And Yeah, this is interferon gamma receptor 1 deficiency causing MSMD. Now let's come to the T cells. Little bit of immunology of T cells, how the T cells develop. Okay, in the first stages, the cytokine signaling is very important for the T cells to develop. And the molecules you see there are IL-2 receptor gamma and the JAK3. Those are very important molecules. I'm just highlighting the important molecules there. The IL-7 receptor alpha, the Artemis, these are important molecules that are involved in the development of T cells. That's how the T cells develop, okay? At the early part, there is a lot of importance of the cytokine signaling and the IL-2, IL-4, IL-7, IL-9, and IL-15. These cytokines are very important in the early lymphopoiesis, okay? IL-7 is very important for T cell development. IL-15 is very important for NK cell development. So if there is no signaling of IL-7, there will be no T cells. If there is no signaling of IL-15, there will be no NK cells. So these cytokines are very important. Okay? So, as I already told you, the T cells, they help the B cells. That's what happened. Now, what happens if there is a defect there in the early cytokine signaling in the IL-2 receptor gamma or the JAK3? If there is a mutation there and these molecules are not working, there's an arrest there. There are no T cells in this patient, okay? Now, the IL-2 receptor common gamma chain defect, that is X-linked. So this will have only males which are affected. And whereas the JAK3 defect, it's autosomal recessive, so both males and females can be affected. Now, what happens if there's a defect in the IL-7? As I told you, IL-7 is very important for T cell development. If there's a defect in the IL-7 receptor alpha there, then there are no T cells, okay? Whereas the NK cells and B cells are preserved. But the B cells here, they are normal in number, but they are non-functional because the T cells are not there. So remember that. So these are again autosomal recessive. Both males and females can be affected. Artemis defect or RAG1, RAG2. Now RAG1, RAG2 are enzymes which are important in recombination, both for T cells and the B cells. Okay. So if there's a defect in RAG1 and RAG2, the T cells won't be there, but the B cells also won't be there. So T negative, B negative kind of a severe combined immunodeficiency. That's how it works. It's so precise. Artemis defect, again, this thing is not there. Okay? And in the later stages, if there is, when the cells ultimately differentiate into CD4 or the CD8, if there is no MHC class 2, there are no CD4 cells. So CD4 lymphopenia. If there's a defect in ZAP70, no CD8 cells. So CD8 lymphopenia. So it's that precise, that precise, these molecules. So if you do a phenotyping in these patients, so that's how it works, you know. The severe combined immunodeficiency are classified as T, depending on the T cells, B cells, and NK cells, as T negative, B positive, NK negative, or the T negative, B positive, NK positive. That's how the classification, looking at the T, B, and NK cells. And you can make a guess, because looking at the chart, you can make a guess on which kind of molecule, which molecule is affected in that kind of patient. This is a case study, 2.5 months old boy, a boy, and 2.5 months, presenting very early, likely T cell defect, and a boy, likely X-linked. So these are points that you have to remember. Presented a fever, cough, and respiratory distress. You can see the WBC count. It is some kind of 13,000 TLC. So there is leukocytosis. Look at the differential count. 89% neutrophils, 5 lymphocytes, 5 monocytes, 1 eosinophil. That's what we look at normally and say that this patient has neutrophilia, okay? And leave it at that. But look at the absolute lymphocyte count. That we are not used to look into. Just look at the lymphocyte count, just 660. This is very low for this patient. It should be at least more than 3,000, the absolute lymphocyte count. If the absolute lymphocyte count in a child presenting in the first 6 months with infections and a low lymphocyte, less than 3,000, this is sure shot, skid. You have to rule it out. I'm not talking of very high-ended investigations here. I'm just talking of looking at the absolute lymphocyte count here. just the hemogram. So if you look at the hemogram very carefully, you can pick up these patients, okay? And then you do the immunoglobulin profile. There's hypogammaglobulinemia because the B cells, T cells not there, so the B cells won't be functional. They won't be producing antibodies. So the hypogammaglobulinemia. And when you look at the immunophenotyping, see, there are no CD3, there's no CD20, whereas the NK cells are there. Okay? So this is T negative, B negative, NK positive kind of a severe combined immunodeficiency. Another 2 months old female child presenting with failure to thrive, pneumonia, and history of previous SIP death. And again, you can see here there are no CD3 cells, no B cells, no CD19, and only the cells which are there are the NK cells. So this is again T negative, B negative, NK positive kind of a severe combined immunodeficiency, and the defect was in the Artemis. Okay, we also published this series last year of the Indian data. What is important in these patients is look at the family tree there. So when you see these kind of patients, you have to specifically ask about the history of their mamajis. Okay? How were their mamas? Because if you see such a strong kind of a X-linked, all the mamajis have expired, see? All the mamajis have. So this is clear-cut indication of an X-linked disease. So if you see this kind of a thing, it's very important. This patient had a lot of BCG adenitis. You can see a smear there, full of mycobacteria. Yeah. Okay. So you can do, by looking at flow cytometry, you can do staining for CD132, which is the common gamma chain, or the CD127, which is the IL-7 receptor. So these are molecules that you can look at by flow cytometry and then confirm genetically. So you can do the flow cytometry assays in these patients. Okay, further down, after the naive T cell has developed into the CD4 and CD8. So these are a lot of other T cells. There are the FOXP3 positive T regulatory cells, the STAT3 producing the IL-17 cells. There are the BCL6 or T follicular helper cells. So a lot of T cell subsets are there, you know, apart from the Th1 and Th2. I mean the helper and the cytotoxic cells. So again, these are not stars, but these are patients. I'm telling you again. We can have defects in the FOXP3. If you have a defect in the FOXP3, the patient would not have any T regulatory cells. If he doesn't have any T regulatory cells, what will happen? Autoimmunity. The patient will present with autoimmunity. FOXP3 defect presents. If there's no FOXP3, the patient presents with IPEX. Okay? Again, if there is no IL-10, the patient presents with very early onset IBD, inflammatory bowel disease. If there is no STAT3 or the ROR gamma T, there are no Th17 cells, the patient presents with chronic mucocutaneous candidiasis because the Th17 cells are very important in handling candida. If you don't have Th17 cells, you cannot handle candida infections. So the patients will, if they have in the hyper IgE syndrome where the defect is in the STAT3 gene, there are no Th17 cells, the patient will present with chronic mucocutaneous candidiasis and staphylococcal abscesses. Okay? Similarly, there can be defects in the IL-17 cytokine causing CMC. So this is the panel of photographs of hyper IgE syndrome. Now, hyper IgE syndrome is a combined immunodeficiency where there is a defect in the STAT3 gene, and these patients don't have Th17 cells. They don't have Th17 cells because of the genetic defect in the STAT3. Now, I'll tell you a small history. The first photograph that you see and the third photograph that you see. The third one, C, is a patient, this is one of our earliest families of hyper IgE syndrome that we had seen in PGI. This photograph, the child in the photograph C was the one who presented at 2 years to the OPD with pneumonia, severe pneumonia. In fact, we could not save this patient. And look at the face of the patient. Look at the eyebrows. They're so widely spaced, such a prominent forehead and such widely spaced eyebrows and flat nose. It's said that these patients, they look different from their brothers and sisters. They look because of the face, they look different from the rest of the family members, okay? Look at the father now. The first photograph is of the father. Now, he was 35 years when he came with his son to the OPD. And look at the face of the father. The same thing, prominent bushy eyebrows. And now the father had history of infections off and on, off and on. He was treated for tuberculosis, drug-resistant tuberculosis and whatnot. Till 35 years of age, when we picked up that he also has hyper IgE syndrome. For the last 35 years, he was suffering. And look at the photograph of his childhood, the second photograph, B. The same features of the father. It was there. It was not picked up because we didn't know. So that's the kind of awareness that we have to bring amongst us to pick up these patients early so that they can be treated. This patient is still under follow-up because I work in hyper IgE syndrome, so I send my students to collect samples and all. The problem with this family is that this father, till today, he has not told his wife that he is he's the reason for the death of his children. Now, these are social implications, okay? He is very hesitant to give samples, and whenever we approach him, he is very hesitant. He tries to keep us away because he is still trying to keep it a secret that he has hyper IgE syndrome, and because it's autosomal dominant condition. So he is the one who is transmitting this disease to the children. So the social implications are there. We have another family of X-linked agammaglobulinemia where the child was diagnosed, and the husband, because he's X-linked, the husband wanted to divorce the wife because he wanted to marry again because he knew that this wife is diseased. So these kind of social stigma that these carry is also important. So that we have to realize. Okay? So, okay, let's move ahead. So as I said, these patients, they have low Th17. If we look at the do the Th17 cell assay, you can see that the Th17 is low, 0.1 in the patient. So very low Th17 cells. And you can also look at the phospho-STAT3 by flow cytometry and see whether the STAT3 is functional or not functional. So flow cytometry has a lot of role in these patients, hyper IgE syndrome. There's another child who presented with a sternoclavicular and psoas abscess, and he held retained dentition. These patients retain their primary teeth. They don't fall off. The most severely affected patients will have double row of teeth. They have the primary as well as the secondary teeth. So a lot of dental anomalies these patients have, okay? So again, you can see that the Th17 cell count is 0.3 compared to the normal of 1.2. CD and memory B cells are very low, 5.3% compared to 22.9. And we look at the phospho-STAT3, it's reduced. So this kind of flow cytometric panel, if you do, in a patient which is presenting with a typical face and the infectious spectrum, and you go ahead and do a genetic diagnosis, look at the STAT3 gene, you have the diagnosis. Okay, let's take up another case. Recurrent scalp and oral candidiasis. This patient, 3 years male child, okay? And we reduced Th17 cells, okay? And we looked at now STAT1 and STAT3, they work in opposite directions. STAT1 inhibits STAT3, okay? That kind of a scenario. So when you looked at the STAT1 here, STAT1 was hyperphosphorylated. So this is a gain of function mutation in the STAT3, which is, there's a lot of hyperphosphorylation of STAT3. It's not only hypo, you have to look at the hyper also. Now look at the lower panel, hyperphosphorylated. So there's a gain of function mutation which causes chronic mucocutaneous candidiasis. This patient presented with candidiasis, oral candidiasis. Okay, so this is a autosomal dominant STAT1 gain of function mutation which is causing the chronic mucocutaneous candidiasis. So hyper IgE syndrome, we published this series, total of 104 cases, I guess, that we could collect pan-India. Okay, now let's come to B cells now. Similar to T cells, B cells also is ontogeny. So we have all these molecules that are very important at different stages of development, okay? And The cells previous to the red bar there, they are in the bone marrow, okay? After that red bar, they are in the peripheral blood. So this T cell is very important here. You can see that's what I've marked. The CD40 ligand sitting in the T cell and the CD40 sitting in the B cell. Now this CD40 ligand interaction is very important to B cell, for the B cells to produce IgG. The B cells, as you know, primarily they produce IgM. Okay? To produce IgG, they have to class switch. Okay, and for this class switch, the CD40 ligand is very important. This interaction between the T cell and the B cell is very important, which happens in the germinal centers in the lymph nodes. So if this doesn't happen, the class switch doesn't happen, which means the B cells can produce IgM, but they cannot produce IgG if this class switch doesn't happen. Okay, let's see. Now, what happens if there is a defect in the early genes like the RAG1, RAG2, or the IgA, or the IgMu, or the BLNK. So what happens is the patient does not have any B cells, okay? Not in the bone marrow, not in the peripheral blood, okay? If you have a defect in the proton tyrosine kinase, the BTK, okay? The cells are arrested here. If you look at the bone marrow, it will have pre-B cells, okay? But nothing beyond, because it's arrested there. So the BTK defect is also called the X-linked agammaglobulinemia, because the gene lies in the X chromosome. So only boys are affected. No B cells, pan-hypogammaglobulinemia. If there's a defect in the CD40 ligand, as I told you, there is no CD40 ligand interaction. There is no class switch, which means the B cells are there in the peripheral blood. They're producing IgM. If you look at the immunoglobulins, you'll have a lot of IgM, but no IgA, no IgG. Okay, so because the class switch hasn't happened here. Okay, so if there's a defect in the CD40 ligand or the CD40, this interaction is not happening, and that's why you don't have any IgG or IgA. Okay. Similarly, if there is a defect in these later molecules like the ICOS, BAFR, they cause, again, the B cells are not there. The B cells are there in the blood, but they are not able to differentiate into plasma cells. So this is common variable immunodeficiency, what we call as CVID. Patients will have B cells, they may be normal in number, but they are not producing immunoglobulins, and they won't have any plasma cells because it's arrested there. So if you have pan-hypogammaglobulinemia and B cells absent, you can think of the disorders at the early phase of development of the B cells. And we have the different combinations. In hyper-IgM syndrome, because the defect in the CD40 ligand, you will have hyper-IgM syndrome, which means the patient will have a lot of IgM if you do the nephelometry, but no IgG or IgA. So that's how it is. Let's take a few case studies. 2-year-old boy with recurrent episodes of diarrhea and multiple episodes of pneumonias in 6 months. Okay? Bilateral discharging ears. Look at the immunoglobulin profile. Pan-hypogammaglobulinemia. IgG is low, IgA is low, IgM is low. And look at the B cells. CD19, no B cells. Okay? T cells are normal, so no B cells. So it's a boy presenting 6 months and pan-hypogammaglobulinemia with absent B cells. This is X-linked agammaglobulinemia. This is the commonest, one of the most common PIDs that we see in our OPDs. Every year we get 3 to 5 patients of X-linked agammaglobulinemia. And very important to note in these patients is absent tonsils and palpable lymph nodes. If you look at the tonsils, they will be absent. I forgot to tell one thing. In the severe combined immunodeficiency, there will be absent thymus. Okay? If you, in this chest X-ray, you can look at the thymic shadow. If it's absent and the patient is presenting with early infections, absent thymus, think of SCID. So you can look at the BTK protein expression by flow cytometry and reduce expression. You can make a diagnosis. Go and do the sequencing and you have the diagnosis of A. Okay, another 28 years old man, symptomatic since age of 10 years with diarrhea, pneumonia, and sinusitis. And the X-ray showed this kind of picture, and the immunoglobulin profile, if you see, IgG is low, IgA is low, IgM is also low. So panhypogammaglobulinemia, now this is not a child, this is a 28 years man, presenting late. So this is CVID. And in fact, CVID or common variable immunodeficiency is the commonest immunodeficiency that we see in adults. Okay, so you have to think of CVID. And in this, you can do the lymphocyte subset analysis. You can look at the switched memory B cells. You can look at the unswitched memory B cells, naive cells, and all these subpopulations of B cells to say where exactly the B cells are arrested. And this is everything you do by flow cytometry. Okay? So you can do a lymphocyte subset analysis for patient with CVID. And this is the panel that we use for immunophenotyping the B cells in patients with CVID. This is an example of a 15 years female child presenting with panhypogammaglobulinemia. All the immunoglobulins are low. CD19 is 9.3, relatively preserved. Okay, 19. There are B cells in the periphery, but look at the naive cells. 66% are naive. No, there's no memory. Only 4% are memory B cells. So there's a defect in the B cell thing. And when you looked at the ICOS expression in this patient, the ICOS expression was low. So ICOS is another cause of CVID. So by flow cytometry, you just looked at the ICOS and then went ahead and did the genetic analysis, and we had a diagnosis of ICOS deficiency. This is an example of the CD40 ligand deficiency. Look at this 6-year-old male patient presenting with pneumocystis cerevisiae pneumonia. And IgG is low, IgM is high, okay, and IgA is low. So this is hyper IgM syndrome because of a defect in the CD40 ligand. Look at the CD40 ligand towards the right side patient. He hardly has any CD40 ligand in his T cells. So this is CD40 ligand expression deficiency giving rise to X-linked hyper IgM syndrome. So what is the initial laboratory screening that you do? I just tried to show you a spectrum of these disorders that you can see. The first thing is the CBC, the complete blood counts. So you have to make a habit of looking at the absolute lymphocyte count and the absolute neutrophil count. An absolute lymphocyte count in an infant which is less than 3,000 is a red flag. A neutrophil count of less than 1,500 is a red flag. So these things you have to keep in mind. I'm not talking of high-flow investigations here. And then serum immunoglobulins by nephelometry. Nephelometer is not a very expensive equipment. You ask Dr. Srinivas, he'll get it in a day. So he'll start doing nephelometry if you start sending him samples, right? So yes, you have a nephelometer. So see, immunoglobulins are like a hemogram for the immunologist. So you have to you start sending samples to Srinivas. And the lymphocyte subset analysis. All these, everything that I have spoken today is you're already doing everything. You're doing all these markers for your leukemia diagnostics. You're already doing it. You just have to, just do a reset and look at these patients in a different way. And the pediatricians which are involved in clinical practice, they have to keep this in mind that these patients are a reality and they are there. They're waiting to be recognized, and you'll see these patients. That's the experience we had in our center. Now, 10 years back, we were not seeing many patients. We were being, Dr. Sujit Singh has been there. He's been trained in PIDs for a long time, so we have been picking up patients. Then in 2011, we had this ICMR Center for Advanced Diagnostics at our center. And we got the machine, we got the funds for, diagnosing these cases. And the curve has risen like anything. We are diagnosing more and more of these cases. It's just a matter of awareness. So T cell deficiency, we look at the T cells, the T cell subsets, and the NK cells, CD3, CD4, CD6, CD56, 16. That's what you actually need for the initial screening, the TBNK. And then you can do the MHC class 1 and class 2. You can look at the CD132, 127, STAT3, STAT1, perforin. All these tests you can do by flow cytometry for T cell deficiencies. For B cell deficiencies, you need the immunoglobulin assays and the B cell numbers. And if you're suspecting CVID, you need the B cell subset analysis. And you have to look at the vaccine responses. For all the B cell defects, you have to look at the vaccine responses, antibody production. For phagocytic defects, the neutrophil disorders, you have to look at the neutrophil count very carefully. You can look at CD18 expression for diagnosing LAD1, DHR flow cytometry, which is very easy to do, can do for the CGD kind of patients. And you can also do CGD for specific proteins like GP91 FOX and P22 FOX and P47. So there's an ever-increasing array, a lot of new disorders keep coming every year. So because now we are waiting for the latest classification in 2022 to come up. So there was this interim report that had come, and they have already added around how many? 26 disorders have been already added again. So these are the new PIDs that have come up, 2 molecules in SCID, the IL-6-ST, which causes hyper IgE syndrome, and these molecules which have been very recently described. And the homozygous TYK2P1104A polymorphism has been linked to tuberculosis. So now tuberculosis becomes a genetic disease. So this polymorphism has been found in the European population in 4.2% in European population, giving a frequency of around 1 in 600 in Europe. And the mean allele frequency of P1104 is over 1 to 2% in other parts of the world. But in those parts of Europe, this polymorphism in the TYK2 gene has been linked to tuberculosis. Okay? Even in COVID, you have these genetic disorders or mutations that have been biallelic loss of function mutations, the IRF7, the interferon alpha receptor 1, heterozygous mutations in TLR3, TCAM1, TBK1, and IRF3. These have been demonstrated in families which had severe COVID infections. So now everything boils down to genetics. Everything, all infections boils down to genetics. Okay? So that is the message I want to convey. And how do we diagnose PIDs? Is the first step in diagnosing PIDs is to think of PIDs. So you have to aware. See, your eyes don't see what your mind doesn't know. So that is very important. You have to think of PIDs to diagnose PIDs. And the second step is to again think of PIDs and think a bit louder this time. Okay? So because these patients, they will come to you with huge files, lot of investigations, because they keep running from one physician to other, and you will have a huge pile of investigations. Still, they will have the persistent infections not cured, because not picked up. Okay? So even looking at the file, even that is a clue for PID, and that's what I'm trying to point. Looking at the thickness of the file, you can see that this patient is actually having a problem for a long time, which has not been picked up. And the third step, think of PID. So unless you think of PID, and there's something called a detailed history, which involves the CBC, a very detailed kind of infections. They have to go through all the investigation that the patient has had, and the very simple investigations like the CBC and the nephelometry. Okay, and there's something in the PID world we say think zebra, which means when you hear hoof beats, you think of horses. अबे zebra भी तो हो सकता है ना? So these are rare things, but you have to think of those rare things. Okay, you don't just think of horses; you also think of zebra, and then only you can pick up these patients. So a careful look at the CBC. I cannot overemphasize this point. It's very crucial, and it's not uncommon in adults. So we see these patients. So it's just the first announcement that I'm going to make in this gathering. We are going to have the 6th International Conference on the IEIs next year. This was supposed to happen this year in March, but this didn't happen because of the COVID. So we're going to have this meeting most probably in March 23, and I invite you all to participate. We are going to have the national conference in December, first week of December in Bangalore. So I don't have the flyer for that. So we have in this international conference, we have a galaxy of speakers, and some speakers are actually the ones who have discovered all these disorders. So a very, very fruitful kind of a conference. I invite you all to participate, come, and thank you so much for being part of this. Thank you so much.
Sir, thank you, sir. That was a wonderful lucid lecture. The lecture has the stamp of Postgraduate Institute, PGI. That is one institute where you have a department of allergy immunology. So you dealt with the depth as well as the fundamentals of the approach to primary immunodeficiency. Thank you, sir. Thank you once again.
So that was an absolutely world-class presentation. Thank you very much, sir. That is the kind of presentation that is, it requires almost 25 years of experience and hard work behind it. The kind of presentation, the cases, collection of cases, amazing. I think we should be very thankful to you, sir, for that sensitizer. It's a really mind-blowing presentation, sir. Thank you very much for sensitizing to this very, very in-demand topic for us. And thank you very much from the bottom of my heart, sir. Thank you very much.
I would request Dr. Radhakrishna Garu to present a token of appreciation to Dr. Bhiman Saikia Garu. Thank you, sir. I request Dr. Bhiman Saikia Garu to present a token of appreciation to Dr. Radhakrishna Garu. Thank you, sir. Now we would like to felicitate our national faculty, for which I invite Dr. Sushma PV, Chairperson and Managing Director, Quantum Speciality Diagnostics, and Dr. Rupendra Srinivas, Managing Director and Quantum Speciality Diagnostics. Welcome, ma'am, and welcome, sir. I call upon Dr. Bhiman Saikia Garu to please take the dais. Welcome, sir. Thank you, sir. Now I call upon Dr. Anil Handu Garu to please come over to the dais. Please clap for the event and encourage us. Thank you. Thank you, sir. Now invite Dr. Manupadesh Singh Garu to please come over to the dais. Welcome, sir. Thank you, sir. With this, we have come to the end of our forenoon session. So to conclude the CME, I invite Dr. Upendra Srinivas Garu to deliver the vote of thanks. Welcome, sir.
Thank you all. Now we have come to the final session, which is vote of thanks. At the outset, let me thank everyone who has made it possible to attend this one of its kind event in our city. Let me start with the IMA, who has given us a big support. Dr. Faninder is here, Dr. Ramani, the president of IMA, and they have put their entire weight behind us, and they made this event very successful event. And with the help of whom we could manage to get a credit hours of 4 from AP Medical Council. We thank the entire IMA Vizag for that. And we also thank IMA immediate past president, Dr. Subramanian Garu, and all the dignitaries, each one of them who have come to the inauguration and the lamping ceremony in the morning. From the bottom of our heart, we will appreciate them being here for this event. And Dr. Ramalakshmi Garu, Dr. Raghunath Rao Garu is the senior most faculty for his time and for his lecture and for the enlightenment that he has given us today. And a sincere and special thanks to all my local faculties who have taken their time out from busy schedules. Even on Saturday, they have busy OPDs. They have made it possible, and they have come here and given us wonderful lectures for all the students and undergraduates and other trainees. I thank all the national and the local faculty members, each one of them. And last but not the least, the main person in putting this entire event together by burning the midnight oil, sometimes giving us all the management team a direction, Dr. Sushma, who happens to be my better half, and the managing director of Quantum Speciality Diagnostics. And the last and sincere thanks to my entire team Quantum, who have been working like almost more than a month, in fact, for putting this everything in place and making it as a grand success. With that, I request each one of you to proceed for the lunch break, and we'll have our lunch, and then subsequent proceedings, Dr. Bindu is going to announce to all of you. Thank you.
Thank you, sir. Before we break for lunch, there are a few announcements for the delegates who are attending the workshop with us. Lunch break is for 1 hour, and workshop will start around 2 o'clock at Quantum Speciality Diagnostics. So I request all the delegates to assemble at 3rd floor of Quantum Speciality Diagnostics. Directions and assistance to the venue will be provided by our volunteers. Thank you.
I think we can break for lunch now. Please join us for lunch. Thank you.